Benny, can you hear me?
Yep, we can hear you loud and clear. Thanks, James.
Okay. All right.
Good morning. All right.
Good morning.
We can get it to a quick because I'm on
Let's see, do we have quorum yet, Bennett? I can't tell by the screen how many board members are here with us. So if you can just let me know.
Yeah, you have 6 of our board members now, and Marco and Jackie are both trying to join. But you have a quorum.
Okay, well we'll wait one more minute. They said they're trying to join, so let's wait one more minute and then let's begin. Hey, Meg, do me a favor. Would you forward to me the document I forwarded to you? I'm having trouble opening it.
Yep.
So the original.
1 second. Yep. Just sent.
Okay. Hello, this is Okay, have Jackie and, let's see, who's outstanding? Have Jackie and Marco been able to join?
It doesn't look like it. I think Bennett's still working with them.
Okay, well, let us begin, just in the interest of time. I want to welcome everybody to the first board meeting of the new year. This board meeting dated January 12, 2021 is now in session. And our scheduled business will start by voting on the draft of the November 10th, 2020 board meeting minutes, which board members have received, and I hope you've had an opportunity to review them. Will a board member move for a vote to approve the minutes?
Move.
May I have thank you, Steve. May I have a second?
Second.
Stanley has seconded. Any questions or edits? Anything needing debate? Bobby, are you signaling that you have?
No, I was just adjusting my light. No.
Oh, okay, good deal. All right. So then I'm going to ask for a vote to approve the November 10th, 2020 minutes. All in favor?
Aye.
Opposed? The minutes are now approved. We will move on to vote on the December 16, 2020 special board meeting minutes, which the board members have also received. May I have a motion to approve the board minutes for December 16th? Stanley has motioned and Steve has seconded. Any questions, concerns, comments, debate? Seeing none, except for the dog. Let's see. All those in favor?
Aye.
Any-
Aye.
All right. The December 16, 2020 special board meeting minutes have been approved. All right. Before we turn to today's agenda, which centers on the city's ongoing COVID response to corrections and 4 variance requests, we have a couple of announcements. Let me first, I don't know if our newest board member has joined us, but I do want to welcome, in case we don't have an opportunity to return to welcoming him, Marco Carrion. He is a new board member, runs a nonprofit in Bushwick, New York, and we are pleased to have him as a new board member. When he comes, we'll try to remember to welcome him once again. Few additional announcements. The first is an update on rulemaking. The board has submitted its draft proposed rule to the Department of Correction, Correctional Health Services, City Hall, and the Law Department for review and certification. We've received feedback from the agencies and we're working through those issues. Our aim is to resolve all issues expeditiously and to receive certification from the Law Department. Once we have received certification, we will hold a special public meeting for the board to vote on the proposed rule in order to open it to public comment. This vote will not be a final vote on the rule, but rather it is a procedural step to open public comment under the city's Administrative Procedure Act. Then there will be the requisite notice period of 30 days during which public comment will be sought. We will hold public hearings during the day and the evening, so all who desire to comment will have an opportunity to do so. After this comment period, the board will review all feedback, consider changes to the proposed rule, send a final rule to the Law Department for certification, publish the final rule, and then vote on the final rule. The proposed rule that we have submitted to the city ends punitive segregation and replaces it with a model that prioritizes safety, accountability, support, and transparency. It aims to ensure that the individual will be separated after a violent incident for the safety of staff, others in custody, and themselves. It aims to ensure that separation is not indefinite. It aims to ensure that people will be held accountable in a system that is based on swift, certain, and fair principles. That individuals will have a due process hearing and their punishment, including the amount of time, defined and expectations made clear and achievable. It aims to ensure that people will be provided with the support they need to successfully re-enter general population and eventually their community. Each individual will be provided immediately with an individualized behavior support plan centered on addressing the root cause of their violent behavior and the services necessary to be successful in their plan. Finally, it aims to ensure transparency. All staff and people in custody must understand and buy into the core principles of this system. It will be critical for the goals, principles, and expectations to be clearly communicated to people in custody before and after any incident. It will also be essential for people to understand the expectations they will be held to and be given an opportunity to meet them. And when they do, they must be rewarded accordingly. The board will continue to have an essential role in monitoring the system, ensuring that the department is operating the model with adherence to the rule. We also are encouraging the city to engage a third-party evaluator to conduct an evaluation of the model to understand in real time its impact on the people who go through it and the jail system as a whole. We hope this system will be a model for the rest of the nation. An evaluation can provide the city and other jurisdictions with this critical information on a new, innovative, humane approach to safety and accountability. I again want to thank Vice Chair Stanley Richards, Commissioner Brand, COBA President Vinny Basio, and Just Leadership USA President and CEO Deanna Hoskins for their diligent work over the last several months. I also want to thank board members Jackie Sherman and Dr. Cohen for their service on the board's rulemaking committee and for their thoughtful insight and input, and the board staff for their diligent work to develop this rule. Our work is not finished, but we will continue to move forward as quickly as possible to end punitive segregation and to implement a system that achieves our goals concerning accountability with humane treatment and safety for all. As the COVID-19 pandemic rages on, we continue to see infections rise across the city and in the jails. The DOC and CHS engaged in heroic efforts to contain the
Chair, hello. I just want to,
All right.
Jennifer, I just want, yeah, I just want to make a brief comment about the rulemaking committee, and thank you for your description of it. I'm strongly support what we're doing, but I just want to say it's taking too long. And it's my understanding that when we submitted this almost several weeks ago to the law department, their job is just to rule on whether or not we're consistent with law, not to be involved in any operational issues. The full board has endorsed this, and it is time to move forward. And I worry when this process takes too long. And the law department does not operate as the city's lawyer, checking for issues of conflict with city, state, and federal law, but rather tries to get involved in the design of the rule. So I just urge everyone involved to get this settled as soon as possible. It's gone on much too long, and I don't see any reason why it shouldn't be approved right now.
I appreciate your comments, and I will just say for the record, I appreciate and I will echo your concerns about this process having taken so long. It's been that's been an issue and a concern for all of us on the board. As it concerns the law department's review, my understanding at this point, I don't have every detail to speak to in this moment, but my understanding is that there are issues that center on whether or not there are provisions of the rule where we have exceeded our authority with respect to some staffing requirements and some other concerns. So my understanding is that the issue that we do have right now with law certification does mainly center on whether or not we have exceeded our authority with respect to certain issues that are beyond our authority. So I'll just leave it at that. We're working through those issues. Let me return to the points I want to make about the COVID-19 pandemic. So we are all seeing throughout the city that that there is a resurgence of the virus. And I do want to, once again, like many members of the board, commend DOC and CHS CHS for their heroic efforts beginning very early on with respect to this virus and its spread, to contain its spread in the jails and to provide care to detained persons. But here we are once again facing a surge and new challenges that present with it. And now we have more information and we have more tools and resources available to us. And so as the virus surges once again, the board and advocates have persistently raised with the city, DOC, and CHS significant and material concerns. And advocates have requested that the board hold a special hearing on COVID-19. Today, we're going to have a robust, very thorough discussion centering on 5 key response issues critical to ensuring against COVID infection and spread in our jails. The issues are as follows: decarceration, housing area density, the testing strategy for people in custody and staff, mask use and vaccine access, ongoing critical service delivery, including visiting and congregate religious services. We're encouraged that the city has begun vaccinating high-risk people in custody, as well as DOC and CHS staff. And we urge them to ramp up those efforts, especially when we look at DOC staff and CHS staff, considering that they are essential workers. A comprehensive vaccination strategy for staff and people in custody is essential for the health and safety of all in the jails and also for people outside of the jails, because there are many people, detained persons and staff, who move in and out of the jails in our communities. Lastly, I want to acknowledge the passing of a person who was detained at the Manhattan Detention Center. This person passed away on November 22nd, and all of the board sends its heartfelt condolences to the family and friends of this individual. Now let's get to the business.
Jennifer, before you turn to the agenda, I just wanted to let you know that both Jackie and Marco are on the phone.
Okay, thank you. Thank you so much. And Marco, before you were able to join us, I know that you and Jackie had difficulties. We did welcome you to the board. We're glad to have you serving with us, and we appreciate all. We know in advance that you will bring a great deal to the board, and we appreciate your being here. Thank you for joining us. And good, I can't see you, Jackie, but I'm glad you're with us as well. So we will now take care of an official matter concerning the reappointment of Stanley Richards as our vice chair. This is an annual undertaking. And as we all know, during Stanley's tenure, he has devoted himself, his time, his energy, his expertise to our work, always taking into consideration the needs and concerns of people in custody and staff. And so I am calling for a motion to vote to approve Stanley Richards as vice chair of the board. May I have a motion? Thank you, Steve. I would appreciate a seconding of the motion.
Second.
This is Jackie, I second.
Thank you both. Thank you both. And let us now have a vote. I'm actually going to ask for you to vote with ayes. All in favor, please say aye.
Aye.
Stanley, I think
Aye.
all in favor. Are there any opposed? All right, the ayes have it, and Stanley Richards has been approved to serve another year as our vice chair. Let us now turn to an update on the COVID-19 pandemic and Correctional Health Services and the Department of Corrections response. Meg?
Thank you. We've asked the department and CHS to provide an update on the response to the COVID crisis. As Jennifer mentioned, today's discussion will touch on several key issues, which we will consider in turn. First, the increase in confirmed cases, the jail population and decarceration, housing area density, testing strategy for staff and people in custody, vaccination plan, and the status of critical jail services. Again, we continue to applaud the work of DOC and CHS and people in custody to mitigate the spread of the virus. We remain concerned about the rising infection rate across the city and in the jails. We are particularly focused on the rising jail population and housing area density and have been working closely with the city and other stakeholders to ensure that these concerns are addressed. As cases rise in the community, among staff and among people in custody, a comprehensive testing strategy becomes increasingly critical. And as Jennifer said, we are encouraged to hear that corrections officers and patient-facing DOC and CHS staff, as well as certain people in custody, are now eligible to receive vaccines. Before we begin our discussion, we wanted to offer our congratulations to Chief Hazel Jennings, who received the city's Department of Citywide Administrative Services and the Frederick O'Reilly Hayes Foundation's Hayes Prize for leading the department's COVID-19 response. The chief was one of only 20 recipients in city government, and we applaud her work and this recognition of her service. The number of people in custody with confirmed COVID infections began to rise in December 2020, following a 7-month period of steady decline. On January 1st, 6% of people in custody had confirmed COVID infections. As of January 10th, the most recent day reported, CHS reported 37 active infections among people in custody. This is a decrease from December 24th, when CHS had reported 48 active cases. As of January 1st, there have been a total of 1,631 DOC staff members and 234 CHS staff members diagnosed with COVID-19. In December 2020, DOC reported 123 new staff cases, accounting for 22% of all new cases reported since May of 2020. CHS reported an additional 15 new staff cases in December of 2020. The jail population has increased 30%, or 1,142 people, since April 29th, 2020, from 3,832 people on April 29th to 4,967 people on January 1st. Just since December 1st of 2020, the jail population has increased 3%. The jail population, this increase from April 29th to January 1st is an increase of 30%. As of January 1st, there were 4,509 people held pretrial, 133 people held on city sentences, 197 people detained solely on parole violations, and 128 people in custody for other reasons, which includes those newly sentenced to state prison and state-ready individuals. January 1st jail population included 726 people who are 50 years or older. This included 44 people aged 50 or older who are held solely on a technical parole violation. And we continue to see the jail population rise and is now approaching pre-pandemic levels. As of yesterday, January 11th, the population reached 5,112. We will now turn to hear from the department and CHS on specific issue areas that we would like to discuss. First, we'll turn to decarceration. On December 22nd, 2020, Chair Jennifer Jones-Austin and I sent letters to the city's district attorneys and judges, along with the New York State Corrections Commissioner, calling for them to remove from jail the people at highest risk of dying from a COVID-19 infection and to allow all who can safely remain in the community do so. We stress the inherent risks of jail during this pandemic: transient, dense, congregate residential settings with thousands of staff members coming and going every day. We also noted our housing area density concerns, partially due to the increased population. In a November briefing with the board, MOCJ reported they believe the increase in the pretrial jail population was due to judicial discretion. The Department of Correction reports that they continue to review people serving city sentences to determine who may be eligible for release under the city's 6A program based on certain risk factors. In the spring, the department released 313 individuals, but as of December 23rd, 2020, only one additional person had been released since then. We would like to better understand the city's plan to reduce the jail population in the face of this emergency. And I will turn it back to Jennifer now.
So several of the board members have, like the advocates, expressed serious concern on each of these issues. And so I'm asking that they raise these questions during this point in time in the meeting, and that DOC and CHS respond. I'll begin by speaking to the issue of decarceration. As Executive Director Eden shared, she and I authored a letter to various stakeholders, DAs, and persons at the state, asking to do all that is possible to reduce the jail system, those who are incarcerated. And we are very much anxious to learn what is the status of those efforts, what is the communication being had, the frequency of coordination and communication with OCA, the state OCA, with the DAs, with the defense bar, with the Department of Correctional Services. We just need to understand what is happening right now. Are people who can be released being released? Are people who don't need to be detained to begin with not being detained? What is the status of those efforts? Is the department with us to respond?
Yeah, we're going to turn to CHS to speak on that first.
Okay, thank you.
Hi, I don't specifically know what the status is of the letters that you wrote to the people who make those decisions, but look forward to hearing what those results are.
What your efforts have been. We're asking what your efforts have been.
Yes, our compassionate release program has preceded the COVID. The first wave, in fact, it just accelerated during COVID. Since March 13th, we've issued more than 2,800 letters on behalf of patients. We've been working with defense, prosecution, and the courts to get people released. We have 1,488 patients who were released. That's 53.1% specifically. And during the second wave, we've issued another 1,529 letters on behalf of patients. We've worked with City Hall and given them lists of people whose medical conditions put them at particularly higher risk. City Hall is working as well with the people you wrote to try and get them released. We have succeeded in getting 9 highest risk people released of the top priority. People who we have managed to get released since March have by very few numbers returned into custody, which is great. They've successfully re-entered and maintained themselves in the community. And our efforts will be unyielding and continuing.
DOC?
Yes, good morning. This is Deputy Commissioner Judy Beal. I'd just like to say we have a very robust review process for reviewing individuals who have a city sentence. There are not a lot of them. And for those that we review, very few are scoring low risk to the community. And so when we conclude the process of review in conjunction with feedback from the DAs, it becomes very clear to us that they are not good candidates to be placed in the community. So we continue to review every sentenced individual, and anytime there is an opportunity to put somebody out because they present as a low-risk individual in the community, we move forward.
Yeah, one pending. One pending.
I'm sorry, and so what are the numbers to date that you've been able to move over the course?
Go out to the community, and we have 1 pending. I'm waiting for response from DA.
And this is a consistent and ongoing effort.
That's correct.
Are there any board members who have any questions concerning these activities? Stanley?
The list that CHS has of the letters you sent, what percentage of those were city sentence, and are you working with DOC to identify high-risk city sentence folks that would be eligible for release or recommended for release.
We are.
I don't know.
Oh.
Go on, sorry.
Was that the CHS question? Okay.
Hi, Stanley, it's Patsy, good morning. We do review the list of people who are city sentenced, and we provide information on clinical condition where it's relevant.
Thank you.
Bobby?
In March, CHS clinical staff took local and national leadership in calling for decarceration as a critical strategy. It's the most important strategy for controlling the pandemic, limiting the pandemic within the jails of New York City. But during this surge, we have not heard anything from CHS regarding the importance of decarceration and limiting the population. Do you think you were right when you called for it in March? And do you think it is important to decrease the population now for you to be able to do your work, to limit the transmission to the community, to limit the transmission to correctional officers, to your staff, and people living in the jails?
Yes, we do. We didn't feel that we needed to sound the alarm because I think the alarm has been sounded. I don't, I can't speak to the courts and prosecution or defense in terms of why the energy seems to have flagged on this. I do still agree that decarceration is a critical piece of protecting people. I would respectfully suggest that even more important might be avoiding incarceration from the beginning.
I'm sure Police Commissioner Shea agrees with you on that.
Are there other board members who would like to?
Just one more question. Did you find any more than one person in the city sentence population who you thought was at high risk and should be discharged for medical reasons? Since December?
Yeah, we're trying to figure out whether we know that or not, but we'll get back to you. And I wasn't, Dr. Cohen, trying to say something about the Commissioner Shea. It was really that there are safe alternatives for people to incarceration that are in the community. So.
This is Jackie.
Yeah. Please, let me just quickly add that it would be helpful for us to just revisit, and we may not have the number available to at this point, but what has been the overall number of people who have been released since the beginning of the pandemic for, on the compassionate release? I think that, and the reason I say that is that the numbers are low right now, but I'm wondering if that's in part many of the people who could have already been released. I want to understand that. Not Jackie, please. Please proceed, Jackie. Jackie? Have we lost Jackie Sherman? It seems as though Jackie is with us, but we cannot hear her. Okay. Are there other board members who have any questions or comments at this time? We'll come back to Jackie as soon as we can reestablish a audio connection with her. So Jackie, just let us know if you can hear us when you're back.
Okay.
You are going in and out, Jackie. You continue to go in and out.
So can I be heard? No? Oh, okay.
I just let her know that she's breaking up.
Jackie, perhaps if you can, as we try to reestablish connection, if you can hear us, if you would email or text your question, comment, then we'll make sure that it's voiced, and we'll try to get it addressed as we try to figure out what's going on. Meg, do you want to continue?
Sure. We will now turn to housing area density. As we've said multiple times in recent months, board members, board staff, people in custody, the defense bar have increasingly raised concerns about the increasing jail population and higher density housing areas preventing social distancing. CDC guidance to correctional facilities recommends that if space allows, the agency provide more space between individuals' beds, ideally 6 feet in all directions, and minimize the number of people housed in the same room as much as possible. The portion of people housed in units above 50% capacity declined steadily from March to early June, and then increased from early June to October. Since October 2020, the portion of people in units above 50% capacity has decreased by 15%, from 82% on October 31st to 70% on January 1st. On December 23rd, the departmental board staff that they had begun testing small cohorts of individuals at VCBC and moving them to open housing areas at OBCC. As of January 1, there was only one open housing area in VCBC with capacity above 75%. This is a significant improvement. While we have begun to see some improvement by the department in reducing density, our concerns remain. 70% of the jail population system-wide is still housed in units above 50% capacity, a slight increase since last week. 36% of the jail population system-wide are in units above 75% capacity. Across units above 50% and 75% capacity, we continue to see a shift from housing in dorms to housing in celled units. Assuming the jail housing configuration on December 30th of 2020, and without accounting for operational and individual specific security factors, board staff estimate that the department would need to rehouse about 858 people in units that exceed 50% capacity. Although some of these individuals could be transferred to currently operational units, the department would also have to open at least 19 general population units. An estimated 50 people in mental observation and approximately 65 people in protective custody units would need to be rehoused to achieve 50% capacity in those units. We will now turn to our discussion on this, and I will turn it to Bobby.
Bobby, you able to hear us? Oh.
Taking a quick call.
Okay, Bobby, when you're ready.
Thank you. I have a few questions for the department and some for CHS. We've as Meg described, we follow this very closely. We issue a weekly report on density, which is public, and it was going in the wrong direction for a long time as the surge increased. It's changed right now for various reasons. One, that the department has opened up a lot of new units because there are now many people within the department who have been exposed or have been infected, and we have to now reestablish the asymptomatic exposed quarantine units and the symptomatic and confirmed case units, and that was appropriate and has caused some reduction in the overcrowding. But as Meg described, there's still substantial overcrowding. So my question to the department is: would you commit to opening additional housing areas to keep areas below 50%? And what are you doing to reduce density in the highest density right now? And what is your goal for housing capacity in each of the areas. I'm going to ask those questions now, and then I have some questions for CHS. Basically, do you believe that you should get to 50% or less? Because it is our analysis of the physical configuration that certainly in areas with fixed beds, that the only way you can give people 6 feet of distance, which we require in schools and in restaurants and every other public space, give that same protection to the men, particularly living in the facility, your facility.
So, good morning, everyone.
Good morning.
It's not a question. I want to put that in context and give you a little data about the department over the past year. So in January of 2020, our population was at 5,700, and of today, we're a little over 5,100. Last year, we had 10 open jails, 9 this year. NBC is actually the 10th jail that is currently open, but only 1 housing unit is open. Back in January of 2020, we had over 1,000 people, 1,016 staff separated from service in calendar year 19. So far in calendar year 20, 813 separated from service. So our uniform head count in January of 2020 was 9,640 people. Today, 8,950. The average sick of our uniform staff was 500 last year at this time. Currently today, it's approximately 1,200. So our estimated daily total of available staff last year was 9,140. Today, it is 7,750. And that includes the 1,934 uniform staff who are currently unavailable due to FMLA, military leave, medically monitored, long-term sick, out on parental leave, terminal leave, leaving the department, and suspension. So while we're operating very much the identical footprint we had last year, our significant resource reduction is impacting how we house people. The department has approximately 1,400 fewer uniform staff today compared to last year. So as looking at the board's analysis, and I thank you for doing that analysis, the simple math of how many people we have in custody versus how many available housing units just does not add up, because it does not account for significant resource reduction. It does not take into account SRG affiliation concerns, separation orders by the court, other safety and security measures that are critical to custody management and housing assignments. So when you talk about just opening up 19 more housing units, it is using facts that does not take into account the entire picture of what's going on here. So there are only 7 closed units at OBCC, 7. So when you ask the question, are we committed to a 50% housing capacity, I cannot commit to that. We don't know where our population is going. We don't know where our staffing resources are going to end up over the next few weeks and months. And so while it may be ideal for social distancing, I cannot commit to that. We cannot work staff triple tours. People do have to go home and get rest. And we cannot staff housing units with people that don't exist. And we certainly can't put people in custody in housing units with no staff.
If I may, Commissioner Brenna, I appreciate the points that you're making. Bobby may choose to respond, and others may have a response as well. I just want to say that I understand the challenges that are presenting. And what I'm sure you also appreciate is that makes all the more critical the focus on those things that you can control, those things that you can manage. And I'm sure you're already thinking about that. We'll talk in a few minutes about the testing strategy. We'll talk about the vaccine access. But, if you cannot achieve the ideal 50% density number, then it makes all the more important the other measures that can be undertaken to contain the spread of the virus. And so I understand what you're saying. And there are challenges sometimes that you can't get beyond because the circumstances are beyond your control. But we do have to focus on what then we can do.
Can I ask a question about that?
Please.
I too, I mean, you've been through so much, and I recognize that. One thing that I'm not clear on is if each place that we have open is half full, I assume, or I know actually, that each facility is structured differently. They're not all the same. So how much of it is, how far do we get with 50% in terms of distancing? And what are the other issues that are preventing us from embracing universal distancing as it is defined, across the whole country and the world? So really what I'm asking is, it can't simply be, how many units are open, how many buildings are open. It's more complicated than that. So how can we get that extra oomph of having people distanced in the facilities that exist, even if they just remain the number that you're using now?
That's a very good question. And we have been working diligently with those who are in our custody since the pandemic began, doing a lot of walking and talking about the importance of social distancing. We have crossed out seats so that people don't sit on those seats. And we explain why it's important to wear your mask, to wash your hands, to stay separated from people. That's why we don't have congregate programs in the housing units. That's why we aren't moving people around the facilities, because we don't want people walking in a line close to each other, moving throughout the facilities unnecessarily. The issue is people have choice, and we are not going to get involved in the use of force to have someone put on a mask or stay 6 feet separated from somebody. For the most part, most of our individuals who are our long-term stayers, or even there for a couple of months, are living in the same unit with healthy people. The healthy people with healthy people feel some sense of security that they're healthy and they're going to remain healthy. And so we minimize exposing people in a particular housing unit who've been living together, the risk by having staff wearing masks, as much as possible, keeping the same steady staff in that facility, in that housing unit, and not bringing people in just randomly walking around, taking tours that shouldn't be there. So we are doing everything humanly possible. I think, as you've acknowledged, as the city has acknowledged, the agency in partnership with CHS has done an excellent job in reducing the spread of COVID in the jails. And so I am open to other ideas. We have discussions with correctional agencies across the country on what they're doing. Quite frankly, I think we're one of the best performing agencies in the country on reducing the spread.
Yeah, I totally agree that you all have done a tremendous job under lots of pressure. Where I'm coming from right now, and I know you're thinking the same thing, is no matter what, we're entering into a period, hopefully we're going to do better. I don't see how we could not do better, but there is a need now for lack of a better word, education and insight of the people that are there, the officers, the inmates, the others that come through the courts and so forth. And I think we need to get creative about it. I'm not saying you're not being creative, but we have no choice because we have a lot of other issues happening. The British version of the vaccine, we've gone too slow in terms of vaccinating people, you could predict that this is going to get worse. And, you know, I'm all for, you know, getting people out who don't need to be there, shouldn't be there, whatever. But just in the moment, I think we have to become very creative and work together.
I agree, and I thank you for that. We have done newsletters, both daily and weekly newsletters. CHS educates their patients when they're in the clinic. We are now out rolling out the educational materials on the vaccine so that people who are now eligible to take the vaccine will take the vaccine. And so I thank you for your support, and I agree we do have to get more creative.
Okay.
Okay. So are there a couple of additional questions I'd like to ask? First, thank you, Commissioner. Certainly, we will work with you to try to understand the relationship between the staff that you have available, the housing areas that are available, and what would be required to get to 50%. And look forward to those discussions with you. For CHS, I was wondering, do you think there should be 50% as a goal in the housing areas? Do you think that the jail should function under the same recommendations as all other indoor situations have been suggested by the State Department of Health, by CDC and DOH as well? That's one question. Could you talk about your engagement with the CDC's December 2nd, 2020 guidance, which provided some new recommendations regarding the length of quarantine and the use of testing, and what is your current policy regarding testing for people in quarantine or in exposed units for new admissions? What factors and guidelines are you using for that? And is there and could you please provide us with any guidelines that you are using for each of these areas? I just say in general, we have found it very difficult to understand the practice and policies of CHS because we hear about things, but we are not provided with all the guidelines that you use. And I understand that they change, and if they change, you can give us the revised ones. But I would ask, as we have asked you before, to provide us with all guidelines for your management of COVID-19 in the jails.
Thanks, Bobby. So I think, as the commissioner said, under ideal circumstances, there would be fewer people in each dorm. But I think it's also to keep in mind that the risks of the jail environment are inherent to the jail environment. So I don't think there's anything particularly safe about a dorm setting where you have 49% of the beds filled. Our experience has been that there are other factors that are much more critical in controlling the transmission of COVID in the jail system. And I would just point out that many of those factors require significant staffing resources from DOC. And we've been able to achieve those things. One of the most important is the reopening of EMTC as a admission facility, which allows us to cohort new admissions in one facility. So I think obviously under ideal circumstances, you would have fewer people in every housing area. But this has not been the most important factor that we've identified in controlling transmission. We also know that the transmission of COVID is very patchy. And by that, I mean that certain infected persons tend to spread it much more than others. And so we see cases in some dorms with very few ongoing transmission. And we see others which may be in areas that are less populated or in cell housing where multiple people are infected. So I think that there are factors that that complicate that overly simplistic fixation on the density of each housing area. With regard to the testing, and the quarantine, we have taken those guidelines into consideration. And in general, we've relied much more on asymptomatic testing than we have in the first wave. And we've been advocates of asymptomatic testing and aggressive testing with our colleagues and in the medical literature. Those CDC guidelines are helpful to help understand and risk stratify what you would expect at any given time point after an exposure or a presumed exposure. But there are many other factors that play into that. Isolation itself has risks, and it has different risks for different patients. If they have comorbid mental illness, for example, or other factors that make isolation riskier, then we have to weigh risks and benefits in each of those circumstances, such that we would not across the board adopt a 10-day time frame with testing as a standard for releasing exposed housing areas, for example. And in general, we still will do at least 14 days for those areas. For a lower risk population, like new admissions, after the initial test and a second test around the 10-day mark, we may release those patients from their new admission housing as early as 10 days, provided we have negative testing at that point. So I think CDC guidelines have informed our thinking, but really what those guidelines speak to is the fact that there's a continuum of risk that begins to drop after 10 days, especially with negative testing. But because of the congregate setting, we have to have a higher threshold whenever we can. So we still aim for 14 days in most cases. But as I said, it's a balancing of risks, and that's why perhaps you won't find a blanket statement or policy, because these decisions need to be made on a case-by-case basis.
Thank you. Okay, I think we can move on.
So I have a comment, Bobby. I'd like to say something. Is James?
Okay, James, good to hear your voice.
Yeah. Last week I looked into RNDC Mark 4 upper, Mark 4 lower. The numbers were in Mark 4 upper north 39, Mark 4 upper south 36, Mark 4 lower north 43, Mark 4 lower south 42, with a maximum number of 50 very high population areas. Commissioner makes a good point. A lot of people are out sick. I know we're at a budget crunch, but are we reaching out for an academy class? You know, I know nobody wants to hear about talking money, but if the department doesn't have the staff, you know, and I'm sure they've gone through exercises, which I've always gone through, like look at all the unbudgeted, who's in offices, put everybody in the field, you know, and I'm sure you've gone through all of that, you know, and you don't have enough staff, just like the police department had to start a class, even though we're cutting down. Corrections, our correction officers, our correctional department, we need staff. And we're in a, you know, situation where we don't have enough staff to separate people. And we all know the important part of COVID is to keep people separated and social distancing. If we can't do that because, Commissioner, you don't have the resources, is City Hall going to give us the resources? Because that's what we need. You know, just one person getting sick because we didn't have the resources to spread people out is just unacceptable, you know, in my point. This is not normal times. This is a pandemic and people are dying. So are we trying to get offices to supply that void that you guys have right now?
So in the borough-based jail plan, there was a commitment to reduce staffing levels here at the agency, and particularly with our population decline over the past several years, that was part of the overall plan. With regard to looking for a new class, that is a huge recruitment effort. We would have to certify a list, interview candidates, do the background checks, then get everybody into the class. The class is 6 months long, so we wouldn't see a new officer on board probably for a year. So that does not help us in the short term.
Okay, thank you.
All right, thank you. Don't believe that there are other questions or comments. And I don't know if Jackie is still with us, and we were.
He is still with us, but still having trouble with audio and trying to dial in. Bennett, can I ask you to help Jackie?
Yeah, will do.
Call in. Thank you. In the meantime, yeah, I think so. So we will now turn to broad-based testing of staff and people in custody, as well as mask use. Between late June and late November of 2020, CHS administered an average of 131 tests per day. The rate of tests administered per 100 people in custody ranged between 0 and 1. This rate increased in December 2020 when the tests administered per 100 people in custody ranged between 2 and 3. And as of December 20th, 2020, roughly 3 tests were administered for every 100 people in custody. From June to mid-November of 2020, the rate of positive tests remained below 0%. As of December 20th, 2020, roughly 3% of tests administered by CHS were positive. On October 14th, New York City DOHMH recommended regular testing of all staff and asymptomatic residents of congregate settings. They recommended at least monthly testing of essential workers with frequent direct public contact, and more regularly for staff of long-term care facilities, as well as monthly testing of residents of long-term care facilities. New York State DOH requires weekly testing of people working in nursing homes. Correctional settings across the country require staff testing, including California, Colorado, Washington, and Massachusetts state prison systems. A federal court in Philadelphia recently required the Philadelphia jail test all staff and people in custody. Currently, neither the department nor CHS require testing of staff, and CHS does not conduct broad-based testing of asymptomatic people in custody outside of new admissions. Since November 17th, there has been testing available for DOC and CHS staff on Rikers Island multiple times per week. And for the first 2 weeks of January, testing is scheduled for 4 days per week. While we have seen improvements in mask use among people in custody and staff, we want to ensure that all stay vigilant. As we know, mask use, social distancing, and regular testing are all critical to preventing transmission of the virus. I will now turn it to Steve.
Okay. A lot of questions I had have been answered implicitly or directly. So I'm going to try to, move it in a way that brings certain things together. Before I begin, though, I want to say that what I would like to hear is the coordination of stuff between all the different entities, CHS, corrections, the courts, and whatever goes on with visitors that do come and others. It seems hard to me to imagine yet or understand yet how, for instance, testing is different with one entity to another. I assume they're not. I assume they're different, but they're all living in the same world with the which is tight, which wasn't designed for this kind of situation, which I think Ross was very direct on this and correct. And we're working in an area where things could rapidly change because there are so many people close to each other. So that is behind it. But I would just begin by this, and maybe it is Ross or Patsy, whoever. I'd like to understand. I think this is true that we're using antigen tests as well as PCRs. And just quickly, I think, first of all, if that is true, I think that's a great thing, because together they can really help us with some of the things that we're looking at. It could take, 6-7 days with PCR easily to become positive when somebody is already positive, and you could find that out with an antigen, even though it's not as accurate. It's not, you can have a false negative, more false negatives. So just the use of antigens, testing and PCRs, and how we're coordinating that. And if we can talk about the other entities here, that would be important too.
Thanks, Steve. So we have a small footprint of not antigen testing, but point of care PCR based testing, which gives us a result in 12 or 13 minutes. We have not relied on that as a critical part of our process, only because the sensitivity is still low enough that we don't always trust it as the final answer. And especially among asymptomatic people, which is the bulk of the testing that we do now. So there is a role for rapid testing, but we don't ever do rapid testing without confirmatory PCR. The critical thing about testing for us has been to maintain our turnaround time so that those results can be useful in actually separating patients from each other during the infectious period. And we've worked very hard with our laboratory partners to maintain that. And thus far, we've been able to. So there is a role for point of care testing. It helps us reduce the need to transfer somebody to CDU. But the gold standard lab-based PCR testing with rapid turnaround has been really the mainstay of our efforts to this point.
So Russ, I totally understand what you're saying, and I think each of the tests are hardly perfect, and because of timing or because of a lot of other issues which are implicit in what you're saying. It would seem to me to be very valuable to be able to. It's not like the antigen tests goes positive for everybody. It's a smaller group, but it has more false positives. It would seem to me, coupled together, you can get through a period of time in a pretty good situation, or when you know that there's been exposure. So I don't want to go on much longer than that, and happy to talk about it again. And we have talked about it, but I just think it's a good tool at the moment, and something that could work here. Now, the other question I have, and I don't know who would, I assume that corrections is doing things slightly differently than you all with the healthcare system, and then there are other entities. I mean, other people come to the facilities, and the people go elsewhere, because of courts or whatever. So how is that being? Just give me an example of how we're. That's a very complex situation with different entities in charge of different pieces of it. Don't be shy.
I'll just do this briefly before turning it over to the department in terms of courts and others, which is that, I think the department and we encourage our staff to get tested as much as, and as often as they wish. It's voluntary. We collectively have testing that's available on site on the island, and that's free to all staff, both the departments and correctional health services. People who have positive test, staff are asked to self-report to the occupational health service of either agency. And I don't know if the department wants to talk about courts and everybody else.
Patsy, did you say they are asked to self-report?
Yes.
Regardless of wherever a staff member may seek a COVID test, either through on-site services that Patsy just described that the department and CHS staff have available, or at private care providers in the community, both of our our workforce staff have obligations to report matters related to their COVID positivity to our representative health departments and their protocols with respect to abilities to return to work and the medical documentation for each of us that's necessary for a staff member to return.
So you're saying obligation, or are they mandated to report that? And my follow-up question is, where does test and trace come in for those officers who test positive? Is this linked to a test and trace? So one is it mandatory, or is it their obligation to report it? And how is it managed and followed up through test and trace at all?
So I'm going to turn it over to DC Feeney in just a second to answer this issue of mandatory and obligation, which is the requirement with respect to the testing and tracing. So everyone's COVID tests, as a matter of public health, are subject to the city and the state's testing, tracing protocols, because those test results are returned in an aggregate to those health authorities. Separately, the positive tests that are returned to either the Department of Correction, and I will speak for Patsy, but I'm aware they have a similar process. When we receive notification of a staff member's positive test, we internally at the Department of Correction, in partnership with CHS, do a contact tracing for that staff member with respect to where they were in the periods prior to the window of positivity, and identify both enhanced sanitation, notification to other staff, and then designation of asymptomatic exposed housing areas as appropriate. But DC Feeney on the reporting.
Sure, good morning. When staff notify the Health Management Division that they are positive for COVID and submit their tests to the Health Management Division, a report is generated that is submitted to me and others in the department. I write to the commanding officer or the manager who is responsible for that staff member and give them the 2-week period of time prior to the onset of first symptoms, where they have to go and identify other staff members that the person has been exposed to, incarcerated individuals that the other has been exposed, and a confirmation that the area has been cleaned and sanitized. The commanding officer and manager submit that information to myself and the Health Management Division, and Dr. Lionheart issues a letter informing the staff member that they have been exposed. The manager then ensures that the staff member is given that letter, and we encourage that they get tested. And the list is generated by both going through the schedule, but also going through the logbooks in the area to ensure that we get everybody that a person may have been exposed to. The list of incarcerated individuals is sent to SCA so that he can send it to DHS. And then the confirmation that the area has been cleaned and sanitized is sent to. So I'd just like to add to that we are still screening at every facility, every person who comes to the front door, having their temperature taken. People are also self-reporting when they are experiencing symptoms of COVID-19 and staying home, calling HMD, and they're not allowed to return to work until they're cleared to do so. So I think by referring back to our average daily sick rate, that's 1,200 uniformed staff members. I believe that we are doing everything possible, and people are responding well to that, to stay home when they're sick.
I was wondering, both for CHS and for DOC. I mean, you each week you have had numbers of your staff diagnosed with new diagnoses with COVID, and it is the policy in nursing homes in New York State and around the country right now that you test staff several times a week, because that's how it enters the jails. I mean, I think your intake process is excellent, and as you described it, Ross, you're taking you're confident in that. Where you're not confident, you're keeping people in quarantine longer. Those are all appropriate, but the virus is coming in from, as Steve said, transportation, when people go out to courts or other situations and are not fully protected, and mainly through staff. So why is not the city taking on the responsibility to protect its own staff and the people that in its care? The 5,140 people who are incarcerated right now, by having all staff, CHS and DOC and any other regular staff and DOC staff, when they return, for example, to be tested on a regular basis. And it's another question, related and unrelated, is, do you know when's the last time you have done sort of a sampling of the jail, so you know what percentage of the jail is currently in COVID infected, rather than as a sampling technique which you'd have some confidence in? And do you have plans to do that on a regular basis?
So I'll answer for the citywide testing or mandatory testing. We've been asked this question every time we report on this. I don't have anything else to add other than the city has not made that mandatory for staff. It is voluntary, and we have put every measure in place for people to take advantage of that. You could test 4 or 5 times a week on Rikers Island, no cost to you, and people have choices. They also can take those tests in the community, and they're not required to report back to us whether or not they have done that. So until the city decides that staff testing has to be mandatory for all city employees, I cannot make that decision unilaterally.
Well, what would happen if we just did it? What would happen if we all worked together to do what implicitly is the right thing to do, to save lives? I believe you that nobody's told you from the city you have to do this, but I think we need to really think through how we're coordinating all the different entities, and are we doing as much as we can? I mean, all we're doing is, quote, wasting money, but we're not wasting money, because you're saving money, because you're preventing people from being sick. We should be blowing the tests out of the park for everybody's safety.
I don't disagree with you. However, I think we would probably step right into some labor issues. And I'm not a labor attorney. I'm not an expert in labor law. I think that would have to be something across the city with all unions.
No, and I'm respectful of that, but I think we have to move forward. We live in a state that has, I mean, we're not living in some of these states that are from another country. People know what's going on and want to prevent it, and we should be really out there. So I'm not going to keep asking it, but Patsy, Ross, I'd just like to hear something about that. I mean, we should advocate for this because it will save lives. More testing, more often, and staying on top of it.
Yeah. This is Jackie speaking. Can I just ask a related question? It's a little narrower in focus, I think.
Yeah, go ahead. We can hear you.
Can I be heard? Okay.
Yeah,
I can't tell if I can be heard or not.
Yes.
I apologize for my connectivity issues today. I guess my question is, and Steve, I've completely agree with the point that you are making. My point is a little bit narrower. My question is a little bit narrower. It's with respect to the staff who are identified as having had close contact as a result of contact tracing. What is the current practice with respect to that staff quarantining and or testing and returning to work after DOC CHS has identified close contact with another staff person, a contractor, or a person in custody who tests positive.
This is Deputy Commissioner. If staff members are asymptomatic and are essential city personnel, they continue to come to work.
And encouraged to be tested.
And encouraged to be tested. You know, and we have that ability to do so right at GMDC.
Jackie, do you have a follow-up question?
The follow-up, I guess, is simply there is not mandatory testing required for that group where we know that they have been exposed, or there is no period of time that they are out post-exposure to identify whether symptoms develop.
No, not at this time.
And I guess what Jackie is actually asking and inferring is, should there be? Will you consider?
We'll take that, we'll take that back and have a discussion. But you're relating it back to mandatory testing. And so we're back at the beginning of the discussion.
Yes, I guess I'm suggesting possibly mandatory testing for a smaller subset of the population when the person has a known close contact with someone who has tested positive. Not as a final step, but I'm suggesting it as potentially a first step in that testing direction.
And I guess I'll go a step further. I believe what Jackie and Steve are speaking to is the circumstances requiring that that at times you have to move beyond what is the the stated rule or the stated norm. And as you demonstrated when fighting COVID in the early months, there were exceptions to the rules that you had to take from time to time. And this is what is being suggested once again.
I'm not disagreeing that it may be the ideal situation, but again, we're back to mandatory testing, and that is something that we would have to discuss with a broader group of folks who could guide us on that.
And I would just, this is Brenda Cook, I would just add that while I can appreciate, and leave to Ross and Patsy to speak for CHS, well, I can appreciate that, the perspective of the identification of, X number, whether or not it be 3 or 5 or 7 DOC staff members in a particular, day or week reporting a positive test, that there's a perception as to what that means, which I think likely contains some assumptions that are just not accurate. Many of the staff who report positive tests based on, information that is available to us and not to the public, there are staff members who are working from home who are reporting positive tests that are in those numbers. There are staff members who have been out for days or weeks prior to, reporting that they've taken a test and that the test is positive. And so the proximity of time for them to have been symptomatic or with representation of the virus, is just not in fact, it's not a factor. And so we know exactly, based on the description that DC Feeney described, and again, CHS does a similar exercise and then addresses it with patients in custody. And we added the designation of asymptomatic exposed housing areas because of a staff member's positive test as part of our development of our protocols over the course of 2020. We have I would say great transparency, and we are not seen the connectivity between staff positive cases and then positive cases with people in custody. Likewise, we're not seeing a connectivity between a staff's positive case and other staff members' positive cases subsequent to that. And so while I can appreciate the conversation here and the push that, you know, some type of even a smaller scale mandatory testing in response to a positive test, you know, should be pursued. I think there's additional facts that when weighed as to the effectiveness of the pursuit of that option, when in fact it involves, you know, mandating a health procedure for staff against their will. I think, you know, there's a lot in the context of that conversation, and I'll leave it at that.
I'm gonna just finish up because I think my part, but so I'll just approach this by stating this because it's similar to some of the other stuff we've talked about. I know that the wearing of masks has gotten better, and I really applaud that because I think that, you know, for some reason it's it becomes a very difficult issue in a lot of settings. I assume, though, maybe somebody correct me, that wearing a mask is not required. And the 6 feet of distancing, which is the minimum. In some of these facilities are very old, the ventilation is bad and not congruent with a healthy outcome. But at least 6 feet of distancing is an issue that my sense is that it's not being followed very well. I think we need to come together and really demand it of ourselves and of others because it will save lives. And I'll end with something that I don't think anybody in this room would disagree with. Massachusetts is vaccinating pretty much all the inmates, and some other states are doing that. I think it makes no sense that we're not doing that in our facilities, both for the inmates, but also the people that work there. I doubt anybody's opposed to that, but this is a potentially very difficult moment because it's going to be a long time until we've vaccinated enough people. And the British strain is here. It's been revealed, and it's going to get into our situation. So I think those three things, masks, distancing, and the vaccine being being available and for the inmates and for the people that work there universally is something it's not a big difference, and it's no different than a nursing home. It may be worse than a nursing home. So I'll finish with that.
That's a fantastic segue. Thanks, Steve.
Okay.
Our next topic is vaccination. On December 23rd, CHS reported that they would begin vaccinating staff in the coming days. And CHS has begun to offer the COVID-19 vaccine to its highest risk patients, vaccinating about 100 people in custody so far. Yesterday, the department sent a teletype to its staff that certain DOC employees are now eligible to receive the vaccine and can sign up for an appointment at the city's vaccination sites. CHS will provide vaccinations on Rikers Island to a limited group of DOC staff whose primary assignment is patient-facing in the jails, including in the CDUs and in the infirmaries. And I will now turn it over to Stanley.
Yes. Betsy, could you tell us what percentage of the CHS staff, patient-facing staff, have already been vaccinated?
Working on the percent, Stanley, hang on.
And a follow-up to that is, what is your plan to have all of the patient-facing staff vaccinated?
Yeah. So if I may, it's Pat. So Stanley, your direct question in terms of CHS staff so far, 24% have been vaccinated. There's we put out a message to try and get more people signing up this week. So far, there's another, another about 40 or 50 people who have signed up, but the week's not over. I can tell you that because I've been involved personally on this since the beginning of December, have advocated that with the state health commissioner and the city health department, that correctional health services staff were in fact healthcare workers, which are part of category 1A in priority for the vaccine. We began that argument in the beginning of December. We received approval and our first tray of the Pfizer vaccine the 4th week of December, the 4th week. We began vaccinating our highest risk staff on that following Monday, and have proceeded through the rest of our staff depending on their risk. At the same time, in early December, that we were advocating for that our staff were healthcare workers, we were advocating that we should at least be able to vaccinate our highest risk patients. We were able to secure that approval on January 5th. On January 7th, we began vaccinating and offering vaccine to about 497 of our highest risk patients. And the way we really were able to get approval for that, and I will note that currently that means that New York City is not only the first, but is the only jurisdiction in the state of New York to even begin vaccinating people who are in custody. The way we were able to do that, and that's different, Steve, than Massachusetts. That's a different state policy. That is not the policy here in New York State. The way we were able to secure approval for our highest risk patients were that we were able to argue that they were clinically analogous to residents of facilities that the state had approved for vaccination, namely nursing homes and residential facilities that are operated by OMH, OASAS, and OMRDD. We continue to advocate that all our patients should be eligible to be offered the vaccine, not necessarily because of their health status, but because of the nature of the congregate setting. We have not yet received that approval, but we will continue to argue for it. So, we began offering to our staff December 28th. We began offering to our highest risk patients January 7th. On Friday, the expectation was on Monday, this past Monday, yesterday, I think, yesterday, it blurs days, that the state opened up 1B, which includes our colleagues at the department. Friday evening, I had a conversation with the commissioner, and that after talking with my team, and we felt that in really light of the close partnership that we have and how highly valuable our partnership is with the correction department, that CHS should lean in and offer to vaccinate the COs. That was Friday night. This morning at 8 o'clock, we began vaccinating the highest priority correction officers whom the commissioner has identified as patient-facing and working in environments where the likelihood both of exposure and higher risk to the COs may exist, but also that the COs may present a risk to some of our more medically vulnerable patients. And we will continue to offer this. I think the uptake among our patients, among our staff, among the COs is low, but I think that's partly because of the general sense of the country that of what this vaccine is and what the Operation Warp Speed really meant. I think there are people, and we've seen it with our own staff, and we've seen it with our patients, that maybe on the first go round, they're saying no, but we're not considering a no or a refusal a definitive no. We think it's more of a, I'm not sure yet, and I need to read more about it and watch people and see people and talk to people. So our plan is to continue to revisit and open and remain open to getting as many people who wish to be vaccinated.
Thank you so much, Patsy. Could you talk, and this is to DOC or CHS, what is the educational campaign, given the reality that many of the officers are Black and brown, many of the people detained are Black and brown, and there is huge skepticism around this vaccination and the history with Black and brown people and the medical community. What are your educational strategies to educate people about the vaccination? What is your plan around using role modeling and peer vaccinations to educate and encourage people to get tested? Is there any work being done around that?
Yeah, sure. And I can, and then I'll hand it over to the commissioner. And most of CHS's staff are Black and brown, and frontline healthcare workers. But that doesn't, that's only awareness. We obviously have, because we have Pfizer, we're a Pfizer house. So we have obviously the Pfizer fact sheet. We have developed our own written material, both separately for staff, for DOC staff, CHS staff, and patients, specific to those circumstances that helps translate a 6-page Pfizer fact sheet into something a little bit more digestible. We've certainly been talking to our staff, Dr. McDonald's, the medical staff under Dr. Rosner have put together sort of a webinar that we're polishing up that really goes through what the vaccine is and what the risks and benefits are. We hope to be able to make that available online so that staff can watch it at their own risk. This is the infectious disease group of doctors who are talking about this. Mm-hmm. For our patients, we have nursing staff actually going around to the houses, explaining to patients what the vaccine is, what COVID is, and I've seen them actually in the dorms going around multiple times, rounds and going back again to try and get more consents and get people off the fence. Staff, both at correction, are suggested to call HMD if they have questions, and CHS to call our occupational health service if they have questions. And our patients are encouraged also to call the health triage line. It used to be called the sick call triage line, but we've broadened the mission of that phone line to health triage to call about any questions they have about vaccine.
Thank you.
So for DOC, we have continued our email, social media posters, DOC TV information blasts. We have an area where there are FAQs posted. We've had an email where people can send questions that we can send back the answers to them. Members of the executive team will be rolling out to the roll calls in all of the facilities, not only explaining where they can get the test, but handing out consent forms, which can be handed back into their admin deputy warden so that we can schedule them. We've had giveaways at not only the testing sites, but we will at the vaccination sites of masks and books. And you'd be surprised how many people are wearing the masks that we give at giveaways because, it helps get people through the door. And so we're making it more of a normal part of everyday business. And we have engaged the unions with the messaging so that we can get it out there, not only the vaccination on Rikers, but also if you don't want to wait for your turn to roll around on the island, it's often quicker to schedule an appointment now in the community. And so I try to lead by example every week. I and every member of my security detail, we go to JMDC and we get tested. And so people have begun to notice that I'm going, chief of staff is going, other members of the executive team are going. And so we're showing it's not a big deal, just go, you're in and out in 10 minutes. And we're leading the way in vaccination. So Myself and all of my detail have scheduled our vaccinations, and we're letting people know that. So there are some who are taking a wait and see attitude because this vaccine is new and there's some skepticism and fear surrounding it. We're doing everything we can to get the facts out to folks, but ultimately it will be their decision. And I think as time goes on, and people have more confidence in the vaccine and that nothing bad happens to you when you take it, especially after the second doses are administered, I think you'll see more of a participation.
Yeah, I think the education and the ongoing communication is going to be critical. We don't want schism between black and brown people because they have no confidence in the vaccine or they don't want to take the vaccine, and those in our society who are affluent and have access get vaccinated, and then we find the percentage of people impacted by COVID continues to be black and brown people or people from marginalized communities. So I appreciate the education that both of y'all are doing around this. One final question. Do we know what percentage of the officers who have been prioritized in the first round have been vaccinated? Like we know 24% of the patient-facing staff have been vaccinated. How many from DOC?
So we just started our vaccination at 8 o'clock this morning, so I don't have that number.
We have a process where we're obtaining the consents, and then we're undertaking the effort of scheduling and the transport. We've got to backfill their posts, and so we're moving deliberately and in process with CHS because obviously the vaccine is a precious commodity, and we want there to be zero waste. And so we're moving through cohorts through the vaccination in partnership with CHS, and we're in hour 3 right now, so we're doing it.
And what I'd like just on our future meetings, being that COVID is so critically important for all of us to be paying attention to, I'd like to just keep this question and on the table. What percentage of the staff who have been prioritized have been vaccinated? So let's just keep that on the agenda going forward. Thank you.
We're happy to do that, Stanley, and I just want to preface this for the questions that I know that will come up. For those staff, and I suspect it will be a large number of staff taking advantage of the city locations, we won't be getting that data. The city will be getting that aggregate data, and so there'll be a lag in information as that's collected and then given back to us. So if the board is looking for aggregate data that way, the quickest response would be to City Hall.
Okay, but we can just keep on whatever testing that happened. I mean, whatever vaccinations that happen through your avenue is what we'll watch. And when we get the aggregate data, we'll keep an eye on that as well. Thank you, Commissioner.
Welcome.
Bobby?
First, a comment, just to.
Bobby, if you can come a little closer, or we can't. It's hard to hear you.
Is this better?
Yep.
It's better. Sorry. First, a comment. And very proud of the work that's being done here. I think it's important to recognize the union was sort of in the leadership on issues of masking and of distancing as well, and hopefully they will provide support in the vaccination process as well. I did not get an answer from CHS about the last time you did sort of mass testing, and would appreciate to know when the last time you found out what the real prevalence was within the jails.
So, Bobby, I think you and I have talked about this at length, and we have resisted mass testing on a schedule because our belief is that asymptomatic testing that's broad-based is tremendously important, but it needs to be nimble, and it needs to be fast, and it needs to be responsive to the epidemiology in the jails. And I think that the undertaking of trying to test all people within the entire system does not even give you a point prevalence, because that test is only as good as that hour or that minute in which it's done. And so our focus has been to look at areas where we have concern for transmission and very aggressively test in those areas. That requires frequent testing and retesting of the same groups, which then raises the problem of testing fatigue, which we also deal with among patients who we have offered multiple rounds of testing to. So I don't have an answer for you on that specific question, but there is a rationale for why I think that that's not an important question, because it will only tell you that the answer at that very moment, which could change from day to day. There is a separate question of, do you have enough surveillance testing so that you know where those problem areas are? And there are a variety of sources of testing that I believe that we do have that, and that we're able to recognize clusters of either symptoms or testing of asymptomatic populations for other reasons, such as transfer to the state system or transfer to infirmary settings, that give us the impetus to do broad-based testing in specific areas.
Well, thank you, Rose. I realize I agree that with your emphasis on the second thing. I also, as is the national recommendation on nursing homes, that should be linked to a routine mass testing. But thank you for your answer.
Other questions?
Yeah, this is Jackie. I have a question. My question is whether you have or are still considering the possibility, this is getting back to vaccination and understanding potential hesitancy to be vaccinated. Have you done broad-based surveying of staff to learn more about staff comfort level, knowledge of the vaccination, or what it would take for staff who are reluctant currently to take the vaccine to do so? What additional steps that might inform future educational efforts?
Thank you for that question, Jackie. It's Brenda Cook responding. So we have, it is not the issue of hesitation or misinformation guiding people's personal decision-making on willingness to be vaccinated is not a unique situation to DOC or to CHS or to people in custody. And so in recognition of that, the city has a really broad effort that is very well supported at the part of the vaccine command center. There are divisions devoted to both preparing materials and protocols and education and outreach, as well as the diversity and equity efforts for the city broadly, and then dedicated to vaccination education and dispelling whatever rumors that people may be holding on to that would be preventing them from taking an action that would be positive for their health and others. And so there's a lot of different mediums coming through those conversations, whether or not they be written materials, video, WebEx, in addition to the video that Patsy described, that they're independently preparing. And so we definitely are engaged, and the city is supporting very deep engagement across the city, and all of the city agencies are taking advantage of that as well to address whatever we can address with respect to people's concerns or lack of knowledge and information that they would need to be comfortable to take what is, in my opinion, an important step for their health and public health.
Okay, thank you very much for that response. I gather from the response is that there has not been and there is no survey effort.
No, part of those, all of the apologies for the lack of specificity. Part of those efforts on both the Vaccine Command Center and the Diversity and Equity Task Force have been many surveys, and the department, I won't speak for CHS, but certainly the department has participated in many surveys and provided and solicited feedback both surveys that go directly to the workforce for them to complete, in addition to surveys that solicit from the agency itself information that we've learned and we've heard with respect to questions, concerns, or areas of where there's a need to be responsive, and we've provided that information back to the city, and then the city is using that information, in fact, to shape those various materials that I've described that are, in fact, rolling out across the city and directly back to the agencies for engagement with our workforce. And DOHMH specifically, in addition to OLR, have been engaged with the Department of Correction related to the vaccine, and will be preparing additional materials and question and answer opportunities for the DOC workforce specifically. And that's forthcoming shortly.
Thank you.
Yeah. And this is Patsy. In addition to what Brenda mentioned, which also involves CHS, CHS also conducted its own survey of our staff to suss out the temperature for vaccine.
Are there any other questions on vaccines or? Okay, great. We'll go to our final topic.
Just one comment. As of today, as of yesterday, people in homeless shelters are eligible for vaccine. The people, because they're in congregate settings, and that should be extended to all persons living in the jails by the city. That's the city policy, right now.
I've raised that, Bobby.
Yeah. Okay.
I've been raising that a while now.
Thank you.
And if I may just add, it's my understanding that that you have been raising that, Patsy, and that your efforts have helped us to get to where we are right now. We appreciate all that you've done, and just ask that you continue, and we will do the same on our end. Thank you.
Thank you, and we will. We're unyielding.
Thank you, Meg.
Thank you. Finally, we would like to discuss critical services, including visiting, religious services, and law library. Since March, critical services have been, normal jail operations have been significantly reduced, including the suspension of visiting, congregate religious services, and law library. On January 5th, board members and staff met with advocates and providers who raised questions and concerns about the lack of in-person visiting, or any plan or metrics for the eventual return to visiting, and problems with availability, scheduling, and technical issues with televisiting. And so I will turn it back to Stanley.
Thank you, Meg. DLC, this is critically important. As it states on your website, there has been for some time now a commitment to visitation and ensuring that family members can be connected to their loved ones who are detained. You have shifted swiftly when the outbreak happened in March, shutting down appropriately face-to-face visits, ramping up televisits, but we've been at this now since March. And there's a couple of questions that the board would like to hear your response to and your planning around. And the first one is, how many people have requested visits, being that the visit guidance is that people need to fill out a form, they need to request a visit, there needs to be confirmation. You have a protocol about how to do that. So can you talk to us about what percentage of the people who applied for a visit actually received the visit? And what have you done when there have been technical issues that have gotten in the way of the visits?
So, Stanley, I'm going to start with an agency response to services, critical services. So I want to bring us back to the whole discussion that we've been having with regard of keeping people safe, both staff and people in custody. And so while I understand and I support wholeheartedly the delivery of in-person services and visits, at this point in time, it would be irresponsible for us to resume any of those things while community spread is at over 8%. And we're just embarking on vaccinations and still trying to get people to test. So I will let Dana Wax speak to the specifics on that, but I really want to ground the discussion in. We know we've been at it for almost a year, and not Many of our 311 complaints are about visits. I think people are finding the ability to have face-to-face visits with people that they would not have had actual in-person visits with, really a comfort. So until we can get this under control, and until we receive guidance from the city with regard to when it's safe to do so, we're going to continue as is and be very creative in the way that we deliver services to folks.
No, and we totally agree. What we're discussing is not should we have face to face. We totally agree. This is not the time to have face to face. But what we are asking to hear is what is your planning around the moment when we can begin to have face to face. We shouldn't wait till the last minute to say now we can do planning around resuming visits. So we'd like to hear your planning in addition to how many people requested visits. But what is your planning to restart visits once you get the clearance from the Department of Health and CHS, and we can begin that? So that's the broader question we're asking. But we agree.
Yeah, I'll let Dana speak to that, but we were ready to reopen visits several months ago and then had to put that on pause. So there is a plan in place, and when we're able to do that, we will just re-implement that plan. So I'll turn it over to Dana for your data request.
Thank you.
Hi, good morning. For those of you who don't know me or who haven't seen me recently, I'm Dana Wax, Deputy Chief of Staff here at the department. Regarding how many requests that we've received related to video visits, first I want to start out by saying that from April 1st to December 28th, we've actually completed over 33,000 video visits and allowed those family connections in a way that we wouldn't have if we hadn't very quickly set up this process back in March. As to how many requests we receive, it's actually a bit of a nuanced conversation, and that's because people understandably submit multiple requests for their visits. They might need to submit the request and then resubmit it because of a change in their schedule or an error. They also may be reached out to by the department regarding an issue in their application that needs to be addressed, and then they'll resubmit their application. So we don't have a unique number of requests per visitor per visit. But what we do is monitor every request that comes in through email, and we work to make sure that people either are connected to their loved ones from that initial request, or if the request needs to be submitted, we work with people to make sure it can be honored. And we feel confident that people do have the opportunity through the capacity we have to meet and see their loved ones through our video visitation.
But do you know, being that, so you have a sub number that is problem applications. How many applications got submitted and got approved without problems? Do you know that? I'm making assumptions here, right? Then I'm making assumptions that you have a system on the website where a person has to fill out a form and it goes someplace. And I'm making an assumption that you have the capacity to be able to aggregate the numbers and take the numbers, separate the numbers based on how many got approved on their first application, how many had problems. Do you know that number? You know how many visits happened?
So I know I can tell you how many visits happen. I can also tell you that on a sort of high level, we receive roughly 220 web form submissions per day, and that on average we're able to conduct pretty close to that number of televisits per day. I think that there is certainly opportunity for us to look into this data further and to disaggregate it and get you an answer.
Yeah, I think it's important because, as the commissioner said, right now we don't have clearance to have resumed face-to-face, right? Televisits is all we have, and the department sprung into action, established televisits, and we're really thankful for that. But I think now is the time to really sharpen our focus on how well is it working, because there's the intention and then there's the actual. And what we've heard from some of the advocates, and I'm sure what you all experience in terms of the challenges of doing the televisits, we want to make sure that we can sharpen down as much as we can this process, because it's critically important, as it's stated on your website. Yeah. So could you talk to me about like what is the process if there is a technical issue, if there's a technical issue or capacity issue from the department? What is the technical response if there's a technical issue from the person who applied?
Sure. So I do want to also begin by saying that we work with people to try to make sure that those technical issues don't happen from the front. And that includes putting information on our website about how to prepare for the video visitation, including checking your tech, checking your video and your camera. And I believe that information is also included in an email that is sent to the person confirming their visit. I'm also aware that our staff, because certainly our goal here is to complete successful video visitation, and so our staff also call the visitor and communicate with them and remind them to check their tech and remind them and work through any issues on the front end. If there are any additional questions, visitors always have the opportunity to call OCGS at any time and any time during their business hours and sort of work through those problems. If an issue happens in real time, I know that our visit floor staff actually have been known to call the visitor and try to help the visitor work through those tech issues that they might be having on their end. And if there's a tech issue on our end, of course, our IT staff are just a phone call away, and we work to resolve any issue as soon as it happens.
And does the department have a person, like if a family member or an advocate has experienced some challenges that they can call? Is it the OCGS you said?
So certainly our OCGS, the Office of Constituent and Grievance Services. In addition, both me personally and a number of people on my staff frequently receive emails and calls from both people in the public and from community provider groups acting as advocates on behalf of community members and help people work through those problems, either if it's an issue submitting the form, or if it's an issue of, I've submitted the form a few times and I'm not getting my visit. So we continue to act as liaisons to support people. Additionally, I know that the public libraries have been in contact with both me and my staff when people reach out to them for support with video visitation as well.
Thank you. And the final question is, what is the plan to re-engage visits once the clearance is given? Love to hear this sort of detailed plan.
Sure. So as the commissioner said, we have been working for many months to get our in-person visitation reimagined and aligned with DOHMH's policies and get something off the ground to find a way to bring those critical connections to people in the safest manner possible. And unfortunately, as we were gearing up to implement that, the cases in the community started to rise. I think that our process will certainly be informed by all that has changed over the past few months related to the pandemic. But overall, in-person visitation will be guided by the DOHMH's core 4 principles: robust sanitation protocols, social distancing, limiting capacity where possible, making sure that people have access to and are wearing PPE. And that's really going to guide the process. And truly, we look forward to bringing it back as soon as we can.
So, I appreciate that, but that sounds like a protocol of how you handle visits. It doesn't sound like a plan to bring back visits. One of the things, I was anticipating and expecting was DLC to say, once visits come back, we've identified a priority population, because we've got to follow the guidelines of priority populations that we would like to start visits with first. Perhaps people who have families, children, would be the first priority to start visits. Then it would be people with blah, 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 blah. Like there's a real plan to say that once we get the go ahead, we could launch reopening visits, and this is how we would be doing it. So I would encourage.
Stanley, let me, this is Brenda. Let me just respond, because I think you're kind of terribly off base with the assumption that we don't have a specific plan. And in fact, Our plan is detailed. It is robust. It includes the scheduling, the opportunity to use the leverage, the scheduling of the video visits for in-person visits. So in fact, we can manage the workflow, which goes to one of the 4 principles that Dana just described in terms of managing capacity. We in fact do not imagine any in our plan to reopen visits, any limitation on the resumption of in-person visits for any category of persons. It is the resumption for all. That has been our approach. That is our plan, and it is based on community metrics and safety from DOHMH as to when that could resume. We have done a massive amount of reconfiguring of our physical space, again, guided by those 4 principles that Dana just mentioned. We've addressed staffing and screening and the distribution and availability of PPE. We were poised to have an entirely reimagined experience to support in-person visits, and we remain poised to activate that as soon as we are advised by the health authority that it's safe to do so. I would add that our partners at CHS have been in contact with us regarding the scope of our revisions and the approach to our plan throughout. And again, we have proposed ways of identifying our in-jail transmission and metrics in addition to the community metrics of the virus in order to make sure that we are keeping health and safety in the forefront of any decisions that we make and any approach that we make. And the idea that if we were to resume visits, that there might be some metric that would require us to curtail or limit or pause. And so there's a very robust plan, and it is a plan to turn visits for all in their entirety in person when it's authorized and safe to do so by public health.
Would you share that plan?
It's with the Department of Health at this point, so it's not authorized.
It's with, we need to talk about this. It's not authorized. The plan, it's not that it's, I'm not asking for the implementation of it. I'm asking for to share the
Sure,
plan.
we can share that information with you, Stanley. We've had many calls with board staff and board members with respect to that visit services reopening throughout the summer and the early fall as we were making those arrangements to in fact activate in-person visits when authorized.
I think I'm frozen, but thank you.
No problem.
I'd like to ask one sort of common question about programs. We're in it. There's no end to this that we can see. So the board will be on a regular basis, continuing its COVID update with you. And one of the components of that will be about programs, not about the biology and testing and stuff, but what is happening. And right now there are increasing numbers of people in the jails. They're staying there 3/4 of a year. 257, I think, is the average length of stay right now, and there are over 5,100 people in the jail. So I would like to not today, but for our next meetings, and we'll give you specifics to know what is happening in terms of programs for these men and women who are spending long periods of time in your jails, relative to education programs, relative to ICANN programs, relative to all the programs that you had been providing. It's time, and I'm sure you're doing this. I'm not criticizing it all. I just would like to hear. We're now living in COVID. We're not waiting for it to be over. So we have to function as we are all functioning in COVID time, and so programs need to be provided for people living in the jails. And just want to just to say that this will be an ongoing concern of the board, and we'll let you know as soon as we can what issues we'd like you to focus on and on this issue next week. But generally, it's a concern that the board has right now. And then there's one last thing. You mentioned someone mentioned the percent of positivity in the community as a marker for how you're going to decide whether to have visits or not. Many people have asked me, what is that number within the jails? What is the denominator? What is the numerator of testing? So we can know what that is for the jails. This is a funny number. All of us who think about statistics understand that it's a weird number. It has to do with who decides to get tested, who's able to get tested, and what the rate of positivity in that particular population is. But nonetheless, it is the number that is guiding all policy in this city and country. And we would like to know what that number is among people who are tested in the jails. How many people that were tested in the last week were positive? Could you tell us that?
So
Question
today,
for CHS. Sorry.
it's for 4.86.
4.86. Thank you.
Yes.
Thank you very much.
Jackie?
Yes, thank you, Meg. And Stanley, thank you for the questions regarding visitation. And Brenda, I fully appreciate the response that you provided, and we'll look forward to seeing the plan when it is available. I do appreciate, I know I have spoken with folks regarding visitation since spring. I guess I would make one further point, and I do appreciate that everyone should be able to have in-person visitation as soon as it is safe to do so. I suppose I would urge as an absolute priority ensuring that as soon as it is safe to do so, and possibly getting creative about how to facilitate that safety, that we look for ways to promote and enable in-person visitation for parents with very young children, for whom video visitation is simply not a truly meaningful opportunity. In order to promote meaningful contact between parents and babies, parents and very young toddlers, we need to find ways for them to safely visit in person. And I fully appreciate that now is not the moment that that can happen, but I do hope that the plan does anticipate that population as a priority.
Absolutely, and I think with respect to, the capacity of our visit floors and the modifications that, we have made to promote and support health and safety, and the ability to continue to have, as we had before, multiple people join the visit in person. All of those things, are supported, and absolutely, as much outreach that we and our programs staff and our social services staff and our facility visit staff can do to encourage and support and promote the return of all in-person visits, but in particular those folks who have children is the value of the department. It's, obviously it's one of our great visiting opportunities that we had longstanding with the Children's Museum of Manhattan and the women from Rosie's to spend time visiting in that environment with their children, and we were poised to expand that for men with another partnership at another borough children's museum, just as COVID set on us in last March. And so, the value of those connections and those family connections of small children is a value that we share, and we'd love to hear from the board how they can partner with our community partners as well to do what we can do as that reopens.
Thank you. If there are any ways in which I could support your efforts here, I personally would be very, very interested in lending my time and effort.
Great, thank you. In addition to recirculating the information on the visit plan, which Dana advises me that we've already have shared, we will continue to share again, but that Dana will connect with you specifically, Jackie, on ways that we may be able to leverage your support, because we have also partnered with community partners on both the televisit initiative and of the return and the promotion, when that occurs, the promotion of the return of in-person visits. So we would like as many partners and credible messengers as we can collect.
Thank you.
Thank you. Any other questions from the board?
Yes, Stanley, I have one question to Brenda. Not to compare the two departments, we have Suffolk County, which has a lower population, but you know, I've called their office and they have a lot of success with programs being done and visits being done on appointment basis. Now, not to compare the two, but have we reached out to see like where their success is? Because I know they haven't had many or any COVID incidents while they've been doing visits, and it's again on a much smaller basis and it's by appointment only. So they're like thinking outside the box. You know, I'm just wondering, could we get some ideas from them, like what their success rate is? I know they have chapel services done since the community opened them up, you know, and they continue to do it with plexiglass and different creative measures. But, you know, I know when we were looking for best practices for young adults, we went to all different states and we brought back best practices. We have some best practices in our own state. I was wondering if we're reaching out to Suffolk, Nassau, and seeing what kind of successes they're having or what kind of failures they're having, and just like put all our heads together and see if, you know, we can come up with even, you know, better idea than just the one they might have and the one we might have. We might be doing stuff better that could even help them, you know, being we're part of the same state. I was wondering if we're at least, you know, thinking outside the box and speaking to them.
Absolutely. I don't know if specifically we have spoken to Suffolk. We have spoken to, I'm aware that we've spoken to partners in corrections, both in the state and across the country with respect to, you know, all of these service delivery and other issues in addition to other COVID operations. And so I can, you know, we can have Dana get back to you on the particulars of what you understand about Suffolk. Dana, I don't know if you have a quick response on Suffolk.
No, I'm happy, Board Member Perino, either to speak to you or to speak to someone you know at Suffolk County and get a better understanding of what they're doing over there. But I haven't personally spoken to anybody, but this process continues to build on itself, and we're very happy to take additional insights from other jurisdictions.
That's great. I mean, you can give me a call. We can make an appointment because they're willing to, you know, set up a date where I can bring a few people over. I was going to bring a few board members also. So having people from the department, I think, would be like amazing. It might be a really great idea. So if you want to reach out to me, I could be the connect on that, and maybe we could do something.
Great. I will call you this week.
Great.
Thank you.
Thank you. Any other questions from the board? With no other questions, we're going to go into the public comment on variances. We will now hear public comment on the department's request for two variances: separation status and young adult co-mingling. We will also hear CHS's request for two variances on tuberculosis and testing and psychotropic medications. I have a list of speakers who signed up to speak. I'm going to call each person's name. When you hear your name, please raise your hand using the hand icon below the participants list on your WebEx screen. If you don't see the participants list, click on the silhouette of a person on the menu at the bottom of your screen. Once you open the participants list, you should see the hand icon in order to raise your hand. When you raise your hand, we will unmute you and you will be able to turn on your video. You can then begin your public comment. I will tell you when you have reached your 3 minutes, and we will move on to the next speaker. You should limit your comments to the requested variances. We will hold a general public comment at the end of the meeting. The board also welcomes written comment. You can email written comment to boc@boc.nyc.gov or mail it to 1 Center Street, room 2213, New York, New York, 10007. I'll now call the first speaker, Maya Williams. Maya Williams, I see you here. I don't see your hand raised. Okay.
Maya, are you there? I'm just gonna.
I see her here.
I just unmuted you, Maya, if you're there. Maybe we'll go back to her.
Okay. Our next speaker is Raymond Ortega. I see Raymond. I don't see your hand, Raymond. Okay. Our next speaker is Kayla Simpson. Are they able to hear Bennett, do you think? Because I see them on there.
Hi, can you hear me?
I can hear you now, Kayla.
Oh, great. We can't raise our hands. There's something going on with the raise hand function, I think.
I just fixed that, so you might be able to. Thank you.
Awesome.
Got it. Thank you, Kayla.
Oh, no problem. Good morning, everyone. Apologies, I can't seem to see a video function. So I'm just a voice in the void.
I just fixed that as well if you want to turn on your video. Sorry about that.
Good morning. And I also apologize for having a toddler in the background. It's peak 2021, everyone. But first, I just wanted to, my name is Kayla Simpson. I'm a staff attorney at the Prisoners' Rights Project at the Legal Aid Society. Good morning, Happy New Year. First, I just wanted to extend a warm welcome to Mr. Carrion. We're very glad to have you on the board. We look forward to working with you and meeting you over the phone and then maybe in person someday. On the variances, we've addressed these requests before. We have the same position that we've always had. The co-mingling variance, the separation status variance, they represent an opportunity to avoid to simply defaulting to a triage response to the real challenges in the jail system, how we manage the young adult population, for example. Because triaging only permits a status quo that we know doesn't serve people in custody or staff. It doesn't set anyone up to meet those challenges. Because it isn't just about co-mingling itself, right? When young adults are housed and where they're housed is of course critical because of how we know the jail system functions, how hard it is to have a consistent approach to a population when it is scattered across housing units and facilities. But it's just one part of the challenge, and the rest matters just as much. How do we supervise those young adults? How do we deliver services to them? How do we encourage participation in school and programming? How do we target violence interruption? And these questions aren't ones that a string of variances can answer, and they need answers. The young adult plan of old, and now it feels of old, attempted to square with those challenges. And imperfect though it was, I think we've lost sight of it. We need to take up that challenge again when the COVID crisis has become more manageable. Okay, sweetie. The theme is this: if you have years of variances requests granted, it's a signal that it's an issue that needs attention, a broader, more thoughtful approach. And that's why we continue to look forward to the restricted housing rulemaking process. Of course, we haven't yet seen the proposed, but separation status calls that question again. It's not just about one unit and one purpose for that unit, but it's about the broader scheme, broader scheme of how deprivation is used by the agency. Pause now because I have to give her some more milk. But I just want to say that we cannot govern these dark corners like separation status and the deprivations therein via variance. And we also hope that when the proposed rule is enacted, we see the board defend it so that in 6 months, a year, 2 years, we don't see the rule chipped away by repeat variances that make the minimum standards less minimum. We genuinely look forward to the proposed restrictive housing rule and to working together to solve these problems. And thank you for your patience with my technical difficulties.
Thank you, Kayla. I see, want to go back to Maya. I've seen her hand up. Maya? Okay, I think she left. No. What about Raymond? Raymond Ortega? Okay. Let's go to Catherine Placencia. Placencia. Okay, Catherine. Oh, is that Maya?
Yeah, it looks like Maya, can you hear us? Can we hear you? We can't hear you.
We can't hear you.
Bennett, can you help Maya and we can try to go to Catherine?
Yep, I will shoot Maya an email now.
Okay, thank you.
Hi, can you guys hear me?
We can. Is that Cat? Who's that? Catherine?
Catherine, yes.
Okay. Go, Catherine.
Good morning. My name is Catherine Placencia, and I am a member of the Youth Justice Research Collaborative. Thank you, board members, for this opportunity to provide public comment on the department's variance requests and the needs of the young adults on Rikers Island. This week, we released a report on research conducted throughout spring and summer. We surveyed youth justice providers in New York City about the experience of justice-involved youth throughout the pandemic. The research included those on Rikers Island. I wanted to share some of the findings to stress the importance of young adults remaining in dedicated units where they have access to age-appropriate services. I also want to urge the department to pursue a mentoring program with older detained people to help support more young adults in custody, especially during the COVID-19 pandemic, when few service providers can work with youth in person. One of the most urgent and alarming concerns raised by the service providers was the dire need for mental health services, both within the facilities and in the communities. COVID worsened the already inhumane and oppressive conditions inside facilities, making these times especially hard for incarcerated youth. Young people who had been detained were severely impacted by the pandemic and struggled mentally and emotionally in their communities, also known to lack supportive services. The lack of in-person connection and interaction with loved ones and support system makes it harder to survive and navigate the criminal justice system, especially now. Young clients need effective programs, services, and advocacy while they are incarcerated. Dedicated systems that provide quality resources, education, mentorship, support, and connection. Service providers recommend investing in youth of color who have been impacted by the criminal justice system. Nowhere is this more pressing than on Rikers Island, where hundreds of young adults should be living in dedicated units with access to robust services and programs. And with the looming second wave of COVID on the horizon, the board must hold the department to its obligation to serve the young people on Rikers. These investments provide disadvantaged youth the tools that they need to succeed. Thank you.
Stanley, you're muted.
My apology. Going back to Raymond Ortega. I see his hand up.
Hello?
Yes.
Oh, can you guys hear me?
Yes, we can hear you, Raymond.
I'm sorry for the technical difficulties with the hand raising feature. But my name is Raymond Ortega, and I am a member of the Youth Justice Research Collaborative. Thank you, board members, for this opportunity to provide public comment on the department's various requests and the needs of young adults on Rikers Island. The young adults on Rikers are young-minded people. They don't have the lifetime of experience that older people on Rikers have. These kids are going through a tremendous amount of stress, and many are losing themselves. Now with COVID-19, they are scared about getting sick and being put with people who might have COVID. People are going to jail at a time when the whole community is at risk, not just because of COVID, but because of how hard the community is right now. Young people need to be together, which is why young adult housing and the programs they get is so important. They can be put anywhere on the island, but they should be in housing areas with their type of people from the same area. Many young people on Rikers Island have history in the child welfare system. Many don't have parents or don't have connections to their families at all. So you need to work with them. You need to get to know them, learn their history, and find out who they are. This only happens when they are treated like the youth they are. That is the point of the young adult plan. I hope that the Board of Correction works hard to make sure that the department keeps the young adult housing units and gives the support they need while they're inside of there, so they can come home with the mindset of being successful. Our project, the Youth Justice Research Collaborative, is putting out findings today from our work, which show how young people are struggling right now. We know how much they need, and we feel we have to stay true to them. Thank you.
Thank you. Have we resolved Maya's audio?
I'm not sure, but let's try it again.
Okay.
Maya, are you with us?
Okay. We'll continue. We'll continue with Robert Camacho. I seen his hand up. Robert Camacho.
You mute me? Yeah. Am I mute?
Yes, you're good, Robert.
All right. Thank you guys, and the Board of Corrections and all the staffs that are there. It's good to put out variance, but we need to enforce some of these variants and making sure that that these variants are what you put out that they say they're going to be, because we see a lot of times when you guys put out variants, it's not implemented and people cut corners. And we shouldn't be cutting corners when it comes to our youth and our kids. No one should be cutting corners. I don't care who it is, because at one time we were all young and we all needed help. And now more than ever with this COVID that are killing Latinos and Blacks like hotcakes, really need it more than ever. So I'm looking at one of the variants in regards to the health and hospital, and it says that at least every 28 days rather than every 14 days. So why is it that they're cutting from 28 to 14 days for psychiatrists to see and evaluate stable adult patients? We really need to answer those questions to make sure that they have what they need. And when they come out, to make sure that we give them jobs and somewhere they can go to. You know, we have this mayor that said that he wants to make more jails in the community because they're from the community. But that's absolutely not true because of the way the rents are. Our people are being pushed far and far away. So we really need to work on when they come home to give them the services that they need and homes that they need, and not put into shelters, because that doesn't help us. That's another correctional facility, shelters. When we have homes that are empty now through the COVID, and people are these fleeing communities like ours in Bushwick, and you got apartments empty, and we got kids that really need a youth, that really need their own to grow, their own place to grow. So we encourage you guys that are there to make sure that we help them in any way possible to come back into this world and give them an opportunity to grow, because you know their minds are growing, and we need young adults to continue to grow with us and continue to stay in our community and help them in any way possible. Thank you.
Thank you. Next is Adeline Sierra. I see your hand raised.
Good morning. Can you hear me?
Yes, we can hear you.
Okay. My name is Adeline Sierra. and I'm a member of the Youth Justice Research Collaborative. Thank you, members, for this opportunity to provide public comment on the department's variance requests and the needs of young adults on Rikers Island. We've conducted research this spring and summer, which we released this week, serving youth justice service providers in New York City about the experiences of justice-involved youth, including those on Rikers Island. I would like to share some of these findings and highlight the importance of young adults having access to the services and support they need while they remain detained. Service providers report that the stress COVID has had on young adults held behind the walls on Rikers Island has greatly impacted their physical health. Young adults have had to share cramped spaces in an objectively unsanitized facility alongside other detainees who have contracted the virus with little to no medical care. Keeping these young adults in these facilities is a health risk not only to themselves, but to other detainees who may be immunocompromised and have been forced to remain in these unhygienic facilities. Another concern stressed by the service providers is the mental health well-being of these young adults. While COVID has affected a lot of our emotional and mental well-being throughout the past year, due to the loss of physical contact and physical interaction, it has affected young adults detained in Rikers and across jails even more so. As stated by the service providers, these young adults struggle receiving adequate access to mental health services as it is, let alone within the confines of Rikers and during a pandemic. There is a great risk of there being long-term effects for these young adults. The board must therefore continue to enforce the minimum standard requirements that all young adults be held in dedicated units with access to tailored, age-appropriate services. This is more urgent than ever before. Our research shows just how fragile these young people are and the current limitations on in-person services available inside. Regardless of where the city's young people are, whether in the community or behind the walls, they deserve to get the care and support they need. Thank you.
Thank you. Our next speaker is Minister Dr. Victoria Phillips.
Good morning, everyone. Can you hear me?
Yes.
Peace and blessings, everyone. Happy 2021. I'm Minister Dr. Victoria Phillips. Everyone calls me Ms. V. I want to touch on several things from several variances. Regarding co-mingling, I'm not going to repeat everything that the advocates have said. I stand with them, but I also just want to touch on something. There's a population in our jail system that doesn't really get the attention they deserve. And a lot of times I see them fall into these co-mingling units. And I've had this issue addressed to me by incarcerated individuals and uniformed DOC staff. And so they're not necessarily titled MO, so they could go to an MO unit. So they still are in general population, but they are the people who are not well received in the population, or their quirkiness or the way they respond to certain stimulus in the population creates certain concerns for security, or certain outbursts around other people in the unit or the house. And uniformed staff is telling me it's really an issue that needs to be addressed, because they really don't know what to do with them. They don't know how to respond to them. They don't know what to do with them, but they know they need a certain level of care, but they're not necessarily designated for MO. And so they're still being put into different units throughout different facilities, and their issues are not being directly addressed. So I promised that I would take a piece of my testimony and address that issue right there. Regarding mental health and things like that, it's still not adequate. The responses are still not adequate. And let's talk about the environment when we talk about someone's mental health. Cleaning supplies are still not up to date. Several buildings on the island and off the island are reporting to me that for weeks they're going without even toothpaste, whether it's DOC issued or available in the commissary. These are hygienic issues. Just Sunday I got calls. My father had heart surgery on Friday, but I'm taking calls from people throughout the jails on Sunday because they know there's a hearing today and they know I'm going to relay their messages to you. On Sunday, I got calls from facilities not even having toilet tissue for 2 to 3 days. How is that impacting someone's mental health? Yes, it's going to greatly impact someone's mental health. And if it keeps up, it's going to greatly impact the security situations in those facilities. Those are issues. Officers reached out to me on the boat, area, I think they said 1B. I got this information on Sunday, and it was confirmed last night that they said at least 3 people had tested positive for COVID. And then there was no real protocol follow-up. People weren't being notified. And they said that they was concerned not just for the people who got to me, said they wasn't just concerned for the individuals in the unit, they was also concerned for them as staff, because DOC wasn't like responding the way they tell you they respond. It's not trickling down directly to the people on site. And so these are concerns. I even testified last year about people in AMKC that was concerned when the captain died from COVID, and the lack of response around CHS and DOC about how they're going to be housed and how they move forward and their access to testing. So these are concerns that was brought up today. These are concerns that trickle into all these variances that y'all are talking about, and these are concerns that will continue to fester if the board doesn't take care of them. And I have so many things I could talk about, so many recordings, but I'll wait to public comment and I'll submit testimony, because there's so many different issues. One more thing with the youth. RNDC, they have new cells, but there's still cells that don't even lock. So when we talk about safety and concerns and stuff, please address those issues. Y'all have a blessed day.
Thank you, Ms. V. Our next speaker is Tobin. Is Tobin on? See your hand, Tobin?
Good afternoon. Can you hear me?
Yes, we can. You can be.
Great. Thank you. Thank you, board members, for the opportunity to speak on behalf of young adults at Rikers. I am Tobin Casa, legal assistant at Children's Rights, which has been a national advocate for youth in state systems since 1995. We are also a member of New York City Jails Action Coalition. Once again, we urge the board to deny all of the department's variance requests. Regarding co-mingling, the department additionally requests the ability to co-mingle 18-year-olds at Rosie's, quote, where the low census of young adults presents housing challenges for young adults with separation or security considerations, unquote. The board should ask the department to explain how housing fewer incarcerated persons increases the need for co-mingling. This does not make any sense. The department's renewal request shows that even with reduced population at Rikers, it still does not have a plan for complying with minimum standards and ending co-mingling. Please deny this variance request as you did at the November 10, 2020 meeting. We all know that separation status housing is punitive segregation. As we have testified repeatedly, the department's variance request once again does not include any mention of the treatment of young adults. It includes no due process provisions. The November 2020 report indicates an average of 39 hours stay in separation status. It remains unclear what proportion of this stay is endured by young adults, a critical piece of missing information. The department notes that, quote, without separation status housing, the body scan machines would be made irrelevant. This would be a welcome development for many reasons, including that it is not clear what level of training the department deems proper or sufficient for staff to operate and supervise the operation of body scanners. Children's Rights also notes that without separation status housing, there would be no need for the long list of onerous variance requests the department includes today. These variances grant the department a great deal of discretion and deny the most basic rights of incarcerated individuals, including young adults. For example, regarding lock-in, there is no provision for out-of-cell time at all, and no possibility of outdoor recreation. This is surely torture. Regarding law library access, the department writes that individuals cannot be transported to library, but does not explain how law library requests will be fulfilled. Regarding access to court and legal services, the department does not commit to ensuring an individual's access to even a virtual court appearance. We respectfully request that the board deny all of the department's variance requests and stop allowing the department to create new forms of punitive segregation for young adults and incarcerated persons alone. Thank you.
Thank you. Our next speaker is Tasha. I see your hand raised.
Can you guys hear me?
Yes.
My name is Taisha Cruz. I'm Carmen Villaman. My mother lost son in Rikers. His name Christopher Cruz, 27 years old. He was found unresponsive in his cell, October 9th. But we still don't know what caused his death. The DOC still hasn't responded to us. They haven't gave us no investigation, and me and my mom are demanding that you guys investigate as to what happened to him and what caused his death. We don't know nothing, but we do know that something terrible happened to him. It's been 3 months and 90 days. We still have nothing. No answers, nothing. Thank you.
Here's the phone.
Can I continue to speak?
You have, yep, you have 3 minutes
Oh,
total.
And we have no cause of death. We don't know what happened. The DOC hasn't responded to me. Nothing. We want to know what happened to him, how he died in their custody, in his cell alone. It's been 3 months and we haven't received no reports, nothing as to what caused his death. And we want you guys to investigate, and we are demanding that you guys investigate as to what happened to him. And my mom is suffering. She don't know nothing. I'm done speaking.
Thank you, Tasha. Thank you. Our next speaker is Julia Davis.
Great. Can you hear me?
Yes.
Thank you. So good morning. I'm Julia Davis with the Children's Defense Fund of New York, and I want to thank you, the board, for the opportunity to talk about the co-mingling variance and the young adults on Rikers Island. So I first testified before this board 7 years ago, and at that time, the city was engaged in, I think, a really transformative process to recognize that young adults were different. And that led to this body ending the use of punitive segregation and solitary confinement for adolescents and young adults, and to develop this young adult housing and the programming that was intended to be delivered there. And the department convened an advisory group of city agencies, of service providers, of the defense bar and advocates to meet to review policies, to discuss issues, to brainstorm ideas for new programming. I just want to recognize with this now renewal of this variance request that we are at a very different place. There is no advisory board. And the department continues to request that this board approve these lists of exceptions to the dedicated housing. And frankly, this extended list of exceptions raises questions about how durable and reliable the commitment to young adult housing and the programming that's intended for young people really is. And you've heard from members of the Youth Justice Research Collaborative, my amazing colleagues who've done work today to present findings from our survey of New York service providers. And I just want to highlight a couple of things that they shared, which is how dire young people's lives are on the island right now, how important it is for the board to engage with the young adult plan, dedicated housing units, the programming questions and issues that Dr. Cohen raised today. And I want to urge you to think about what we can do more for young people rather than less. I want the board to reject the department's commingling variance request. And importantly, I want the department and the board to work together to develop this mentoring program with older detained people to try and fill in the gaps that we know are there because so many young people are not receiving in-person services on the island right now. This is a time for flexibility and creativity with a real focus on young people as a special group who rely on you, who you've recognized in your rulemaking and your work over the years. So with that, I want to thank you very much.
Thank you, Julia. I understand we have Maya Williams back. Her audio is fixed. And her hand...
Hi, good afternoon, everyone. Can you hear me?
Yes, we can hear you, Maya.
Okay, I'm sorry about the technical difficulties, but thank you for giving me the opportunity. My name is Maya Williams. I'm a member of the Youth Justice Research Collaborative. Thank you again for allowing me to provide public comment on the department's variant requests and the needs of young adults on Rikers Island. Early this spring and summer, we surveyed youth justice service providers of New York City to understand the experiences of justice-involved youth, including those in Rikers Island during the COVID-19 pandemic. I wanted to share these findings, which we released today, to stress how important it is that young adults remain in dedicated units on the island with as much age-appropriate support as possible. Service providers have shared that their clients are experiencing heightened traumas during the pandemic, both mentally and emotionally. Service providers shared that their younger clients are feeling despair, fear, isolation, and the scarcity of mental health services, resources, and support to help them is even less present than there was before the pandemic. Ignoring the mental health needs of young people is excruciating and dehumanizing. We call on the Board of Corrections to require that DOC house young adults together to increase access to age-appropriate services and support. Because of limited access to in-person services on the island from community-based service providers, we also support the creation of a mentor plan, working with older detained people to support young adults in these dedicated housing areas. This is the time for creative solutions that recognize the unique needs of young adults. Older youth, like those on Rikers Island, are constantly left out of conversations when it comes to their risk in detention. We know incarceration is not the solution. Until we can end detention for youth and support more young people in the community, we must do everything possible while they are detained to meet them with the dedicated program they need and deserve. Thank you for your time.
Thank you, Maya. We're now going to Melania Brown. Yes. Okay, I see your hand. Yes, we can hear you.
My name is Melania Brown. I am the sister of Laylene Polanco, who died at Rikers Island on June 7th, 2019. My sister died alone in the cage within a cage. Solitary confinement first was introduced in 1829. That's 191 years ago. And the same concerns that were present then are still present now. Insanity, suicide, and coming out more violent than before they went in. And please stop using COVID-19 as an excuse to abuse the practice of this torturous system that's already in place. Of 24 hours a day, these humans are only getting out of this cage for 15 minutes a day. Some come back with a negative COVID test, and they're still placed there for the remaining of the time, which is 14 days. If there's no visits allowed because of COVID, there should already be something in place for family members. I am a mother of 3 daughters that are affected by the fact that they cannot see their loved ones. Every day I struggle with them having anxiety, them breaking down, the teachers calling me saying that their behaviors are changing and they are becoming uncontrollable. If you transfer an inmate already from a facility where he was already quarantined or she was already quarantined with a negative test, they shouldn't have to do and repeat another 14 days. That is complete torture. The mayor promised to end solitary confinement in the name of my sister, but no one has kept me informed with anything. I have to come to these meetings in order to know what's going on and keep myself up. I strongly feel you guys owe me to keep me informed. After all, my sister's blood is in your hands. She died under your care, in a cage within a cage, where the COs you guys protect so much failed to do their jobs and follow protocols, checking on her every 15 minutes. Stop saying you're sorry. It's played out. Stop saying you're sorry and do something about it. We don't want to hear your you do it. Actions do speak louder than words. My deepest condolences go out to the family of Christopher Cruz. Taisha Cruz, I know exactly what you're feeling, and it does not get better. Trust me. But all I could say to you is you keep pushing. They had me and my family as well in the dark. It wasn't until I started fighting and grabbing a mic 3 days after my sister's death to start pressing on on the fact that my sister is no longer with me and what was going on with her. It took a couple of months after that, a lot of pain, a lot of me repeating the same stories for them to come back with an answer that wasn't even a full answer. My heart goes out to you, and I am here with you. I am here with you, and I'm holding your hand through it. I know how it feels to lose someone to the DOC. I know exactly what you're feeling. And to be in the dark, you and your family, not knowing what happened to him, not knowing if he was calling out your name. I think of that all the time when I think of my sister, Leilene Polanco, which should have never been in solitary confinement to begin with. She was placed there against the objectives of medical staff. My sister was true to herself. My sister was loving. Now I walk around with her around my neck. Instead of hugging her like I used to on holidays, her birthdays, my birthdays, watching her play with her nieces, I got her wrapped around my neck in ashes. Thank you, guys.
Thank you. Thank you, Melania. We're going to go to our next speaker, Jennifer Paris. Jennifer, are you with us? Okay. Okay, I see your hand. Jennifer, you can begin. Are you your audio's open?
Can you hear me now?
Yes.
Okay. Thank you very much. I actually asked to speak at the end of the meeting, but I will go ahead and speak now. I'm just very disappointed to see that this board has not yet moved forward with its rules to end solitary confinement. 6 months ago in July, after the mayor had announced the working group, the Jails Action Coalition and the Halt Solitary campaign were very clear that we believed that this was the wrong path, and we encouraged you to abandon it. We saw that it would lead to much delay, and that's exactly what's happened. Not only has there been delay, there's been a complete lack of transparency. That working group never released its findings to the public, yet all of the other members of the working group know exactly what was in it. The ones who are left out are the activists, the people who are formerly incarcerated, who've lived through this experience, and family members of people who are incarcerated. It's completely unacceptable for this delay to continue and for there to be no transparency in this process. We urge you to complete rulemaking as soon as possible.
Thank you, Jennifer. Our last speaker is Victor Herrera.
Can you hear me?
Yes, we can hear you, Victor.
All right. Good morning. Good morning, Johnny Richards. Good morning, everyone. Thank you for letting me speak today on these variance requests by the Department of Corrections. And honestly, this is it's like directly related to what I have to say. Prevention is an important factor in which many of the courts and DAs behind the rise in the jail population are not factoring when bail is considered. Okay, the least restrictive means should be a top measure in keeping with bail reforms and detention under the present COVID-19 pandemic. DOC variance request should be denied based on a human rights violation evident in this multi-agency concern that needs to be resolved before this board considers the DOC's request. Bail is about assuring appearance, not profit. All agencies should be accountable on the COVID-19 social distancing enforcements. for all humans, detained or otherwise. High risk is a label that can be easily manipulated across all agencies, courts, DAs, and DOC in pretrial detention. Variances should be strongly considered only when all agencies are involved in transparency as to what parts are being appropriately considered. Okay, that's basically what I really wanted to say, because they're requesting variances and all agencies, there's absence of agencies that are basically responsible for the detention of many of the individuals that are, high risk. Really, that label can be utilized in many ways. Okay, and I feel that DOC, okay, can easily manipulate that factor. Okay, especially when they are housing individuals in solitary confinement and stuff. And really, this variance shouldn't be considered right now unless courts or the DAs or those agencies that are involved in detention are also included in this hearing. Thank you.
Thank you, Victor. This concludes the public comment concerning the variances. We will now go into the variance. I believe we're going to do CHS variance first. And Jennifer is back, correct?
She may have had to step away again. I can do the overview of the CHS
Yes.
variances. Just give me 1 second. So their first variance is on psychotropic medications. The board first granted this variance in November of 2005. The variance allows psychiatrists to see and evaluate stable adult patients on psychotropic medications in general population at least every 28 days rather than every 14 days. This is consistent with the community standard. As of December 22nd, 2020, 38% of the jail population had a psychotropic medication prescription. 1,840 people had a psychotropic medication prescription out of, at that time, the 4,878 people in jail. This is the highest reported rate since the data was first reported in June of 2013. The previous high was 37% in June of 2020. Of the 1,840 people on psychotropic medication in December of 2020, 50% were on a schedule of 15 to 28 days. This is similar to the last reporting period when 50% of people on psychotropic medications were on a 15 to 28-day schedule. There are 533 general population patients with a 14-day psychotropic medication order. CHS reports that many of these people are only on 14-day orders because they have not yet been in jail long enough to receive a follow-up appointment, or that they require closer psychiatric attention. I will now turn to CHS to present their request.
Thank you, Mike. So we're renewing the request for this variance, which was first granted in 2005. And as we've discussed before, this really allows us to tailor our care to the needs of our patients as judged by the patient and their caregiver together. Many patients do not need to be seen with a 14-day interval, and this allows us to provide the best care to our patients.
Thank you. Can I ask for a board member to move to vote on this variance?
So move.
A second?
Second.
One question, Stanley?
Yes, I'm opening for discussion right now, Bobby. Go.
Thank you. Would it be possible before this variance is, when this variance is renewed the next time, to prepare for the board a more detailed report, specifically addressing the rising percentage of people receiving psychotropic medications? Not asking you to explain that right now, but if you could give us a report which would help us understand and help, I'm sure you understand it, but help us understand what is different from before in terms of diagnoses, in terms of medications being used, in terms of who is writing the prescriptions, why this number is increasing.
Yes.
Thank you.
Any other comments from the board? Okay. Do we have conditions on this?
We do. There are no conditions on this variance.
No conditions. So let's ask for a final vote. Do we have to go through the motion? No, because there's no conditions. So we can just go for a final vote by roll call.
Yeah.
Stephen? He signals yes. Bobby?
Yes.
Jackie? Is the audio, Jacqueline's audio fixed?
Yes.
Okay.
Can I be heard? Yes.
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 We hear you.
Okay, great.
Felipe?
Yeah, here. Sorry.
James? Is James with us?
Bennett, is James still on? You know?
Give me 1 second. I think you got.
Yes, I'm still on.
Okay. Your vote? Yes.
Yes.
And our newest board member?
Yes.
All right. Jennifer's not on right now, right?
I don't believe so.
Okay. So the variance passed. Let's go to the second variance, Meg.
Yep, this is on tuberculosis testing. The board first granted this variance in July of 2013. The variance allows CHS to use either interferon gamma ray assays, IGRA, or TST for tuberculosis screening, and to exempt from repeat screening those people in custody who have documented a negative test in the 6 months prior to their admission. At the January 2018 public meeting, Dr. Cohen responded to safety concerns raised and stated that the exemption from repeat screening is safe and consistent with public health recommendations on screening for tuberculosis in the jails. I will turn it over to CHS.
Thank you, Meg. Nothing to add.
Okay. Ask for motion.
Move.
A second. Stephen. Any board discussion? No discussion? Do we have any conditions?
We do not.
No conditions. So let's go to roll call vote. Start with Stephen.
Support.
Felipe.
Support.
Jacqueline.
Yes.
Bobby.
Yes.
James.
Yes.
Marco.
Yes.
And I vote yes. And I was remiss. I did not vote on the first variance. I vote yes to the first variance as well. So this variance passed. Thank you, CHS. We now go to DOC, correct?
Yes, we'll take separation status first.
Separation status first.
The department restarted using body scanners for the detection of contraband in July of 2019 after the board and many other stakeholders supported a change in state law to permit their use for this purpose. The scanners, like those in use at airports around the world, use low-dose ionizing radiation to detect objects such as drugs and items made from materials that are undetectable by magnetometers or stored in body cavities and not found through other methods. When someone has a positive scan or refuses to be scanned, the department believes the person possesses contraband and places them in a highly restrictive housing area called separation status, which includes the person's confinement to an isolation cell for nearly 24 hours. DOC will remove a person from the unit after the person receives a negative scan indicating the absence of contraband. The board last renewed this variance at its November 2020 public meeting. At that meeting, the board expressed continued concern about untrained DOC staff scanning people in custody and untrained DOC staff supervising scans and placements into separation status. The board added a condition that would immediately withdraw this variance Should an untrained staff member use a body scanner or review body scan image in relation to admission to or discharge from separation status? There have been no placements in separation status since the November public meeting. The department's internal audit of scans in November found that all audited scans were conducted by properly trained staff, and 63% of scans were supervised by properly trained staff. The department reports significant efforts have been made since November in regards to training of supervisory staff. The department reports that investigation division investigations of staff cited in internal audits of training are ongoing. They anticipate various related investigations and disciplines to be dispensed as early as this month. I will now ask the department to present their request.
Yes, good afternoon all. This is Chief Stu speaking. Pursuant to section 1 through 15C of the New York City Board of Corrections, minimum standards of the City of New York, Department of Correction, request a limited 6-month variance, renewal from the BOC minimum standards, outlined within this letter for the purpose of maintaining the safety and security of the department's facilities. The individuals in custody are known or reasonably believed to have dangerous contraband secreted on or within their body. The department seeks this variance to take effect on January 14th, 2021, the date upon which the current variance is set to expire.
Thank you, Chief. Can I get a motion to move?
Yeah. Move.
Second. Felipe, thank you. Second.
Hi, I don't know if you can hear me, Stanley. I'm trying to second.
Okay, thank you, Jack. Open for discussion.
Stanley,
Yes, Bobby.
I would like to ask the department two questions. Why, through December, were only 60% of people admitted to the jail, or 70% getting scanned? And secondly, why have there been no scans in December, and have there been any scans in the first part of January? I know that the board limited its last, I believe the board limited the length of time for the last variance request on this item because we were concerned about the lack of training and a particular incident where someone was placed inappropriately in the separation status unit, not independent of refusing to scan. So again, answers to the question about why why 70% only of people are being scanned, and why no one was scanned in December, and what's going on right now with scanning.
So, good afternoon, Dr. Cohen. With regards to your statement of persons not being scanned, that is not accurate. Persons are continued to be scanned in our correctional facilities. Since our last board meeting, we have conducted nearly 3,000 scans. As of the last date of January the 7th of 2021, we have done 2,810 scans, resulting in 13 items of contraband recovery.
What about December? Were scans done in December?
Yes, I don't have the exact number of scans that was done in December. However, there were scans in December, and there were contraband recovered during the month of December. Some of the contraband discovered was prior to a scan. There were others after a positive scan. I wouldn't give the entire listing, but I'll just give a brief synopsis of some of the contraband that was discovered during the month of December. On December the 8th, a person, before going through the body scanner, surrendered a battery. On another date, a person surrendered a green lighter after a positive scan. On another particular date, a person surrendered one sharpened piece of plastic before a scan. And the last two was after powder scan, where a person surrendered one 2-inch piece of a metal nail, and another person surrendered one broken piece of a pen cap after powder scan.
Chief Stukes, is the EMTC is your admission unit right now? Are you performing intake scans, and EMTC, and is there a scanner there?
There is a scanner at EMTC. However, that scanner is not being utilized. EMTC is a annex to the Anaheim Call Center, where there is a operational body scanner. As it pertains to the policy, new admissions are required to be subject to a body scanner. However, in our efforts to prevent the spread of COVID, the persons in EMTC are quarantined for the certain amount of days as CHS has stated during their testimony today. However, upon the person being cleared and being transferred into general population, they are subjected to a body scan.
I see. So when they go through quarantine, then they are scanned at AMKC. Is that what you're saying?
For whatever facility they're actually transferred after they get the clearance by CHS to transfer out of EMTC, yes.
And all the other facilities have scanners?
The other facilities that have scanners, not all our facilities, but we have, Rosen Singer doesn't have a scanner, however, AMKC, GRBC, OBCC, they all have body scanners.
Okay. Thank you. Sorry about it. I had misinterpreted, I guess, our data, which suggested that there were no scans done in December. I apologize for that.
You're welcome. Thank you.
I'd like to just to understand this, and I think to underscore this, you've done a number of tests and you have gotten the testing down to a point where either people are relinquishing weapons before they get scanned or immediately following the scans, and you have not had to rely on putting people in separation status because the process and engagement that you've established is really working. Am I hearing that right, Chief?
That is the goal, Stanley. That is correct. Our goal is not to place persons in separation status, although that is a choice. Our goal is our contraband recovery with our efforts of keeping our staff and persons in custody safe.
I want to acknowledge that. I think that's really, really good work. Thank you, Chief.
You're welcome. Thank you for the compliment.
Any other questions, comments?
Yes. What percentage of the staff who are assigned to do scanning have been trained at this point? Or where are you at in the training?
So I would just like to add that any information that we receive regarding persons not trained and operating or supervising the operation of the body scanner, we take it seriously. I know there were conversations at our November meeting regarding supervisors who were not trained, who were signing off on body scans. Since then, we have trained all those persons, and we continued our efforts of training supervisors. We had a class on yesterday, which is on January 11th, and we have 2 classes scheduled for the upcoming next week, January the 18th and the 19th, and the 21st and the 22nd. With our goal is to get as many supervisors trained as possible.
Thank you.
Thank you.
If there are no further questions, if we have any conditions, Meg will read the conditions.
Yes, we have a number of conditions. So the department is asking for a 6-month variance. We're recommending a 4-month variance, which would take us to, I believe, May of 2021. I will read the conditions now. Condition 1, all newly admitted people in custody shall receive a medical and mental health intake per minimum standard 3-04 prior to body scan. 2, the department shall place a person in separation status only if the person, 1, has a positive body scan, or 2, refuses a body scan. Condition 3, the department shall A, house people in separation status within 4 hours of a positive scan or refusal to scan absent extenuating circumstances, which shall be documented and communicated to the board in each instance. B, notify CHS of each person placed into and or released from separation status upon conclusion of each tour. Each notification is to include a notification to pharmacy and mental health and individual specific information. For people released from separation status, DOC shall provide CHS with the person's new housing location. C, CHS shall provide daily medical and mental health rounds to people housed in separation status and shall have the authority to determine if any person should be removed for clinical evaluation or treatment. D, institute one correction officer to one person in custody observation of each person throughout placement in separation status and fully document such observation. E, provide opportunities for regular visiting and attorney visiting by a secure video conferencing system. F, the department shall consult with the Office of Court Administration on producing people in separation status to court and shall produce any person the court orders to be present. If the court requests that the person not be produced, the department shall, to the extent possible, enable the person to participate in his court proceeding through a secure video conferencing system. Condition 4, when a person remains in separation status for 72 hours, the chief of department, the bureau chief of security, and the GRVC warden shall meet to develop an individualized plan for moving the person out of separation status. The committee shall meet and develop a plan every 72 hours until the person is moved out of separation status. The department shall provide each written plan to the board within 1 business day of the committee's meeting. Condition 5, upon request, loose leaf legal materials shall be provided to people in separation status. This shall include legal mail and law library requests. The department may institute limits on the number of loose leaf pages a person may have in person cell at any given time. Condition 6, the department shall afford 1 hour per day of indoor recreation for people in separation status. Recreation will be provided on a housing unit in a closed space, but outside of the person's assigned cell. Recreation space shall include appropriate recreation equipment. Condition 7, the department shall not limit the number or duration of confidential calls to attorneys, the Board of Correction, the Department of Investigation, or any other monitoring body. Condition 8, signs shall be posted at intake to advise individuals in custody that they can make complaints about body scanners, body scanning to DOC's Office of Constituent and Grievance Services, or 311, and upon release from DOC custody, request the total accumulated radiation exposure from all body scans of that person conducted during the incarceration. 9, by the next business day of a person's placement in and release from separation status, the department shall provide the board access to all supporting documentation related to a person's placement and release. The department shall provide the board a monthly public report the requirements for the report and the report are outlined in Appendix A here too. Condition 10, the department shall offer a daily opportunity to body scan to each person in separation status and document such offers. Condition 11, the department shall provide access to newspapers and magazines. The department may limit the number of newspapers and magazines that a person can sell at any one time. Condition 12, all staff operating or supervising scanners shall have completed radiation safety training and body scanner operations training. All staff reviewing and approving separation status and placements and removals shall have completed training on image evaluation. 13, upon placement, all people in separation status shall be provided with verbal and written information on how to access services, all restrictions to services while in the unit, the right to a daily scan, the potential risks of ingesting or secreting contraband, and the right to individualized counseling on those risks, and an assessment by clinical staff in a clinical setting. This information shall be readily available in the separation status unit in both English and Spanish and any other language the department deems necessary. Condition 14. The department shall provide access to media via phone calls. Media interviews via phone shall be scheduled via the requirements of minimum standard 1-14B and DOC's media access policy. Condition 15. If an untrained staff member uses a body scanner or reviews a body scan image in relation to admission to or discharge from separation status, the variance is withdrawn until the department demonstrates it has cured the problem. Conditions.
Thank you, Meg. Can I get a motion?
So moved.
A second? Thank you, Steve. Would the department like to respond to any of the conditions?
No. No, we're good with those existing conditions, Stanley. Thank you.
Okay. Any debate on the conditions? No debate. Let's go to a roll vote. Let's start with Stephen.
Support.
Jennifer? Jennifer, support. Bobby?
Yes.
Jackie? We can't hear you, Jackie. Felipe?
Support.
James?
Support.
And our newest member?
Support.
And come back to Jackie.
Yes, can you hear me now?
Yes.
Yes, I vote yes. Thank you, Stanley.
Great. Thank you. The variance passed. It's a variance for 4 months, not the 6 months. Let's go to the next variance.
The next variance is co-mingling. In January 2015, the board passed a new minimum standard that requires DOC to house young adults separately and apart from adults. The revisions were designed to reduce violence by segregating developmentally distinct age groups, fostering age-appropriate rehabilitative opportunities, and ensuring compliance with local and federal Prison Rape Elimination Act standards. The rule went into effect for 18-year-olds, but has never been fully in effect for 19 to 21-year-olds. The board repeatedly granted these variants to the department between the fall of 2015 and the fall of 2020. On November 5th, the board considered and denied this variance. On December 14th, the department submitted a limited 1-month variance request to house young adults with adults only when required by management needs. Only when required by management needs pertaining to safety. This variance was passed at a special meeting held on December 16th, 2020, and allows the department to house young adults ages 19 through 21 with adults ages 22 and over if the young adult is housed in a restrictive housing area with less than 14 hours lockout, has engaged in violent or assaultive behavior towards staff or other people in custody, has engaged in actions that threaten the safety and security of the facility, qualifies for protective custody and cannot be safely housed in young adult protective custody units, is being quarantined as part of the new admission process during the COVID-19 emergency, has applied and been accepted into the special consideration unit, has a centrally monitored case, or is a young adult housed in the Rose M. Singer Center. The department is requesting an extension of this variance and to extend the exceptions for commingling young adults in new admission quarantine housing and women at Rose M. Singer to 18-year-olds. Board staff recommend the removal of the notification requirement for young adults in the new admission quarantine, since the reason for commingling in the circumstance is time limited and for routine new admission purposes, and merely creates an administrative burden on DOC. Board members, board staff, and DOC staff also met in December to discuss the department's plan for a mentoring program. Board members agreed to send resources and to use reference for building the program and to use as reference for building the program. And the department said they intend to draft an initial plan with the board for feedback. Most young adults in DOC custody are housed in young adult units or in specialized units where commingling is permissible per the effective board variance. Since the November meeting, the proportion of young adults housed in accordance with VOC minimum standards or active variances has increased by 18% from 84% on November 10th to 97% on January 4th. The number of young adults in any form of restrictive housing on November 2nd was 38, while the total number of young adults in any form of restrictive housing today is 65, which represents a 71% increase in the number of young adults in restrictive housing. I will now turn it to the department to present its request.
Yes, good afternoon. I'm presenting a request for a limited 6-month variance to Board of Correction minimum standards regarding the co-mingling of young adults 18 to 21 years old with adults 22 years and older for a 6-month variance effective January 16th, 2021. As of yesterday, we had a count of 433 young adults aged 18 to 21 within our system. Of that, the vast majority are housed in pure young adult housing. We have 68 that are co-mingled in some way, shape, or form. However, out of that 68, 50 are either CDU status or going through the new admission processing at EMTC. We have 2 GP young adults co-mingled within RNDC. And there are 2 co-mingled female young adults at Rose M. Singer. The remaining, and we have 1 co-mingled young adult in ESH level 3, and that was due to a recent incident, a fight within the young adult level 3, which required a separation issue as they lock out as an entire tier. So it was done as a safety precaution. The remaining young adults are either in AE housing, waiting for CHS to clear those units so they can be transferred into RNDC young adult housing, or identified in some form of medical or mental health housing unit. And finally, we have 1 in S special consideration unit, and 2 are co-mingled in adult protective custody units due to separation issues from being housed in the young adult protective custody units at RNDC. So again, for safety precautions and separation issues, those 2 individuals are commingled within adult PC units. And that's where we are today.
Thank you. Can I get a board member to move the variance? Jennifer? A second?
Second.
Thank you, Jackie. Any discussion?
Yes, I got a discussion, Stanley. This is James. Commissioner Farrell, in October, you had approximately, I believe, like 59 uses of force. In December, you had 132. And it's obviously because the commingling, you limited that to 2 individuals. Your facility in RNDC, on the other side, you house almost 400 adults. Out of those 400 adults, you have about 203 high classification and medium high. Now, having experience, and I believe you were the commissioner when I was a warden there, we had over 50 low classification detainees, which made it easy for us to handle, for the warden to handle the other side. Plus, we had more space to move people around. Now, commingling too is like outstanding, right? That's great. But looking at the uses of force going up, you know, what I suggested last month was have programs where you have maybe a few more extra offices, less detainees. Are you working on that? You know, because, you know, obviously it's going up and we don't want, it's obviously a problem. And knowing, you know, my thing was never to end commingling. It was to minimize it to a level where most of our kids are getting the programming. So are you guys working on special housing areas with extra offices, lower detainees, or, you know, I would strongly suggest over 200 high classification guys in that jail. It could be an ingredient for an explosion. Would you be able to go back to what we did? 2015, I major myself, 2014, where the warden had to just deal with older guys, which created less problems with, you know, a lower classification. I mean, we know it worked, you know, so are you working on that? Because commingling is something I feel is necessary, and I've always said it. It just has to be, you know, controlled, and the minimum amount of our kids, you know, go into adult population. So I know I said a lot. I'll give you opportunity to answer that.
So as far as the commingling, we're very judicious in how we identify individuals to commingle with the adult population. Behavioral support plans are adjusted to manage those individuals, but I will let Chief Jennings speak on the incident and the management of the operations at RNDC.
Well, good morning. I just want to thank you, James, for your input in the matter that the commingling portion of it is important. When we previously had the older gentleman 50 and above and over at RNDC, it worked. However, right now, when we talk about the spike in violence, it has really little to do with the adult population. It is the young adults. And right now, we have been managing them in RNDC. And if you look at the young adults house, we have, for a housing area, hypothetically, there are about 5 officers, 2 floor officers plus an aid station in each one of these young adult housing areas. And we have single to low double-digit numbers in each one of those housing areas. And so we have been monitoring how we have been adding the new admissions into the house. We are monitoring how many persons are in RNDC at the adult population. But as we spoke earlier, our census has continued to rise, and we will have to use some portion of that facility for adult housing, where we also have our state-ready population in RNDC. So we are looking at it on a daily basis. We are monitoring it. We're projected this month for RNDC to have a 38% decrease in their uses of force. Previously, we've done really well with the facility. And as we start to add, we did see a spike, but we are going to continue to monitor that to do whatever necessary adjustments are needed.
Okay, sounds good. One real quick question. What do we, even though it's really beginning of the month, what's projections for January? Because it seems like each month has gone up. And
so right now for January,
I know you're not going to have that many uses of force with the adults high classes as much. That's not my point. My point was lowering, and again, you're in a situation where you can't because of the population, but you know, look to lower that number so you have more places. And again, we're speaking the same language because we work together. So if you have more places to move your problem children to move around and stuff, you're going to have more, you're going to have better results, you know, where if half that facility or 400 people are adults, you're not going to have as, you know, much room to move around. And to be honest with you, when we just started the young adult population with all the kids that we had in C73, you know, it was very explosive when you put everybody in that one spot. Again, that's why I do support commingling. Absolutely. I'm concerned that only 2 people are commingled, where, you know, I can't see everybody getting to get along except for those 2 people. You might have pushed it way to the other side of the limit, you know, looking at the uses of force, you might have, and you need to take a look at that also. It's not about the number. It's about, you know, keeping people safe. And with, you know, with only 2, like how does that procedure work? Does the warden recommend, like how many people did the warden recommend, for instance, maybe in the month of December, and how many people did you approve? Are you guys on the same page with that? Because I know the warden's like boots on the ground.
So yes, Warden Caputo is very aggressive with his acts, and we are working with him on a daily basis as to how he needs to manage his population. And we're also looking at, on a daily basis, space that may be needed and how we could possibly readjust population. So we're working with him. And we have to make sure that we are finding a happy medium for how we're managing these young adults.
Okay, sounds good. Like I said, I mean, going from maybe like 30 to 2 was like very aggressive and very impressive. The only thing is, looking at those uses of force, it's starting to, you know, we don't want another C-73 happen like maybe 2014, and then say, oh my God, at the last minute, you know. And again, like I said, I've always been for co-mingling. I was just concerned that the number was getting very high, and some of our kids, problem kids who really need this program, was being left out. But it seems like now you're getting mostly everybody in there, which is pretty impressive real quick. So I just, you know, my main concern probably is those high classification detainees in that facility, along with the kids. But it's really impressive, the numbers that you're showing compared to just a few months ago. So good job, Chief Jennings. Well said, well spoken, and thank you for that response.
Bobby? Thank you, James.
I echo almost everything that James said.
We can't hear you, Bobby.
I echo almost everything that James said, although I, do not think we should have co-mingling, but it sounds like at this point it's working fairly well. I just want to clarify what one of the ways it has worked, and James talked about this, and Commissioner talked about it, Commissioner Farrell talked about it, is having low numbers of people with large numbers of staff in the young adult dormitories. Chief Jennings, did I hear you say that you're going to be taking away young adult housing areas and replacing them with adults because of an increased population?
No.
No. But you said there are going to be more adults coming into the facility?
No, what he asked about was that, do we think that we need to take out more adults? And I said, not at this time, that we're monitoring it on a daily basis to see about the needs. However, we do have spacing where we need housing areas, and so we have adults there. But right now, the adults are not contributing to the increase in the incidence.
Right. And thank you. And also, how has the increased population affected the young adult program? It's gone up fairly dramatically over the past several months in general. I wonder if you've seen how that has affected the ability to deliver programs or any other issues.
Yeah, so Ms. Frances Torres will speak about the programming.
Good morning, everybody. Actually, good afternoon. Hi, Dr. Cohen. Programming continues to be afforded at RNDC, just the same way that we have during the pandemic. Programs will be very happy, based on your statement earlier, to do a thorough presentation at our next BOC meeting. But the increase on the number of young adults does not impact how programming is being done, especially at RNDC. You know that as part of this commingling variance, any kid that is commingled is assessed and is also given or works with a program counselor or counseling staff in his development or her development of an individual support plan, and that continues to be the case. You know also, and I hope you know also, that there are very specific programming opportunities that are being afforded at RNDC. And even if the kid, when commingled within RNDC, with the adult population, has access to those programming opportunities, significantly programming opportunities given at the Peace Center. But we will be more than happy to give you and the rest of the board members a very thorough presentation of programming at the next BOC.
Thank you.
Thank you, Ms. Torres. Bobby, if I can chime in.
Yes.
Ms. Torres, I know that you guys have been struggling on how to get outside providers to meet with kids. Is that happening? Are you using technology to make outside programs available?
I think I will need you to give me very specific examples, Board Member Franco. I know that when it comes to programming for the young adults, we have had to place a hold on most of our contracted providers who were supporting our efforts pre-pandemic, just to ensure that we keep the population as well as our staff safe. There are very specific programs that the kids have access to. You know too well that we've been speaking to you about some of the programmers or program providers that never left the island, that have been here as part of our workforce development. So whether you are a young adult or an adult, within very specific guidelines that we've implemented to meet PPE requirements, social distancing, we've continued to afford OSHA 30 certifications. We've continued to afford barbering, barista, culinary arts, automotive, and significantly at RNDC, we have done very specific changes to how we do programming, from the number of participants to enrolling those courses, as well as how the practicum portion of it is to be done. For an example, we don't do barbering on one another. We don't allow that. However, we allow mannequins to be used and so forth. Now, when you talk about remote learning or any type of video conferencing.
Yeah, Ms. Torres, again, sorry for first of all, thank you for clarifying the significant amount of programs that are available around education and employment. My question was more about outside providers that I know are being able to work remotely through virtual connections to young people in the YCD, at DOE, at ACS, and even at the Department of Probation. Are we working on using technology to allow those important connections with outside positive influence to happen?
When it comes to the Department of Education being a mandate, it's become our priority. At this time, we're waiting for the Department of Education to let us know when it is that it will be able to provide administrative and supervisory.
So maybe we cannot talk about it today. When we meet about programs, could you present to us how you are using your contracted providers and technology to ensure that young people sustain positive connection with outside programs and contractors?
We'll be more than happy to do that.
Is there a timeline on when you're going to use technology to bring those programs back in?
It's something that we'll provide you separate and apart from public hearing.
Thank you.
Any other comments?
Yeah, I had a question for Chief Richards. I first again commend the department for having reduced the number of young people who are commingled with adults. Can I hear more about where these young people being housed? I mean, which units, what sort of adults are they connected to particular adults because they could be a good influence? Are they connected to particular units because they are more peaceful? How does it work in terms of decision making and moving a young adult to an inappropriate adult population?
So for the young adult population, we limit the housing unit sizes for medium high to high class individuals at 25. We have cells and we have dormitory housing. And as far as the commingled housing units, there's only 2 young adults. They are housed in a cell setting within a housing unit with 22 and older individuals. And those have a maximum capacity of 30 cells each.
Is there an integration process on when a young adult comes to cohabitate with adults?
Part of the co-mingling process is programming unit receives the information and it prompts them to revise their behavioral support plan so that they are aware of the housing unit location, so they'll be able to deliver and provide the appropriate assigned programming.
Yeah, Commissioner, my question was more about, is there a meeting with the adults before a young adult gets placed with them? Is there a conversation about the role of adults with young adults? Is there a meeting with the staff before the young adults get integrated into the adult unit?
So one of the things that Warden Caputo does do is when they have their yard team to bring the young adult there, there is a conversation that that young adult will be coming to a housing area.
The conversation is with the adult inmates, Chief?
The adult inmates and the warden of the facility, yes.
Okay. And what is the message that is communicated to the adults that are receiving?
I don't know the specific message. I do know that it's being done. I have never been there for one of the interventions, but I do know that Warden Caputo is having that conversation.
It would be fantastic to learn more about the message of welcoming and integrating them into the units.
No problem.
Thank you.
Thank you, Felipe. Any other comments, questions?
Well, just it seems to me that you just have two people being co-mingling right now. It doesn't seem like this is a that you're able to run the young adult program without co-mingling. So I'm glad to hear that, and I think there's we should therefore take that into account when we have to reconsider this variance now.
I wouldn't say that we're able to run the young adult program without co-mingling. Co-mingling is, as indicated, a necessary tool to be able to use and manage our population as a form to intervene with a young adult who is having issues and is starting to become problematic and needs that adult level of environment to provide supervision, provide housing. So I wouldn't say that we don't need it. We certainly do. And, that's evident by our current co-mingling and the options we have available.
There's also the need to commingle in medical units, in as you see now, the COVID quarantine units. So a blanket statement that we don't need it would be a dangerous thing to perpetuate.
I agree. I agree with you, Commissioner. I meant in terms of the non-exclusions.
But I think, as Bobby said, we should acknowledge the hard work that you put into really making sure young adult only housing is happening. So congratulations to you on that. If there are no further comments, Meg is going to read the conditions.
Yes. Sorry. One moment. Okay. The department is requesting a 6-month variance. We are recommending a 3-month variance, which would take us to April. So the board would hear again in March. The conditions are as follows. Condition 1, the department shall house young adults separately and apart from adults in young adult only housing units unless the young adult A is housed in a restrictive housing area with less than 14-hour lockout, B has engaged in violent or assaultive behavior towards staff or other people in custody, C has engaged in actions that threaten the safety and security of the facility, D qualifies for protective custody and cannot safely be housed in a young adult protective custody unit, E is being quarantined as part of the new admission process during the COVID-19 emergency, F has applied and been accepted into the special considerations unit, G has a centrally monitored case, or H is a young adult housed at the Rose M. Singer Center. Condition 2, The department shall apply the factors enumerated in conditions 1A through H of this variance on a case-by-case basis and shall place a young adult in housing with adults on an individual determination that the young adult meets at least one of the criteria set forth in condition number 1 of this variance. Condition 3, the department shall house male young adults in RNDC unless the young adult is housed in accordance with exceptions enumerated in conditions 1A and 1D through G of this variance. Condition 4, the department shall develop an individualized behavior support plan for each young adult in commingled housing. Condition 5, all young adults in commingled housing shall have access to programming and access to young adult programming and supports young adult commingled pursuant to conditions 1B and 1C shall have access to the Peace Center at RNDC. Condition 6, the department shall consult with correctional health services programming and mental health staff prior to making each commingling determination. Condition 7, the department shall notify each young adult in writing of his or her placement in commingled housing. Such notice shall be served upon the young adult within 48 hours of such determination and shall specify the criteria and the young adult's conduct upon which such determination is based. The young adult shall sign a notice indicating his receipt thereof, or if the young adult refuses to sign, staff serving the notice shall indicate on the notice the person's refusal to sign. This requirement shall not apply to young adults commingled in new admission quarantine housing during the COVID-19 emergency. Condition 8, the department shall document each commingling determination in writing, which shall A, specify which of the criteria enumerated in condition 1A through H of this variance form the basis for housing the young adult in commingled housing. B, describe in detail the young adult's conduct, including date, time, and place of such conduct that resulted in the determination to house the young adult in commingled housing, if applicable. C, include the young adult's individual behavior support plan and all CODs and incident reports or other documents supporting the determination. D, indicate how the placement is consistent with or will promote the goals of the young adult's individual behavioral support plan. E, state what other young adult housing units were considered for placement of the young adult and the reasons why the young adult were not placed there. F, the requirements for condition number 8B through E shall not apply to determinations made for young adults meeting criteria for condition number 1E. 9, the department shall send the board a biweekly report of all commingling determinations, including the reason for the determination and all supporting documentation. 10, during the pendency of this variance, the department shall provide the board with a weekly census showing A, in which housing units and facilities young adults ages 18 through 21 are housed, and B, the number of young adults who during that week are moved from commingled to young adult only housing. And condition 11, the department shall continue to provide the board with a monthly progress report on its implementation of the young adult plan and implementation of alternatives to punitive segregation, and provide its progress report for each month on the 10th business day of the following month. Those are the conditions.
Thank you, Meg. Can I get a board member to move the conditions?
How long is this? I'm a little bit confused. Is this 3 months or 6 months?
We're suggesting 3 months. That would take us to April. We don't have a board meeting in April, so we would hear it in March.
Okay.
A motion to move the condition? Jennifer? A second? Stephen, did you?
Yep.
Let's do a roll call vote on the condition. Felipe?
Approved for 3 months.
Approved, Jennifer?
Approved for 2 months.
Is it
2 or 3?
Is it 2?
It's 2.
So we were, Steve, so we were saying 3. We could do it either way. So we were saying 3, which would take us to April. We would hear in March, or you could do 2, which would just be to March.
2.
I will vote for 2 now that I have the option.
Okay.
2.
Okay. Steve,
2.
Bobby,
2.
Jackie,
Yes to 2.
James,
Approved. 2.
Marco.
2. Yes to 2.
Okay. Well, does the department want to respond to any of the conditions? On the proposed conditions?
No, that's good. Thank you, Stanley.
Any debate on the proposed conditions? We're clear it's for 2. Now let's do a roll call for the conditions and the vote, and the variance. Felipe?
Yes.
Bobby?
No.
Jackie?
Yes.
Steve?
Yes.
James?
Yes.
Marco?
Yes.
Did I get you, Jackie?
Yes.
And I vote yes. Jennifer had to step off. So we have 1 no, remaining.
Jason, Megan, did you guys watch the hearing yesterday?
Oh, are you?
Yeah.
Okay, Jennifer's yes. So we have 1 no and the remaining yes. The variance and the condition pass. Thank you, everyone. We're now going to go to public comment. Am I right?
Yes.
Okay, great. Okay. As I said, we're going to hear from the public. This is open comment. I have a list of speakers who signed up to speak. I'm going to call each person's name. When you hear your name, please raise your hand using the hand icon below the participants list on your WebEx screen. If you don't see the participants list, click on the silhouette of a person on the menu at the bottom of your screen. Once you open the participants list, you should see the hand icon in order to raise your hand. When you raise your hand, we will unmute you and you will be able to turn on your video. You can then begin your public comment. I will tell you when it has been 3 minutes and we will move to the next speaker. You should limit your comments. You can have your comments be open. This is the open general period. We also welcome written comment. You can email your written comment to boc@boc.nyc.gov or mail it to 1 Center Street, room 2213, New York, New York, 10007. We will now begin the open comment period. Let me just get the list. Let's start with Jordan Rosenthal. I don't see Jordan on here. Okay, let's go to Kayla Simpson, and I see your hand is raised.
Can you hear me?
Yes.
Okay, wonderful. Hello again. I'm Kayla Simpson, staff attorney at the Prisoners' Rights Project Legal Aid Society. Look, it is worth repeating every single month that the city is creating serious risk in the jails that does not need to exist. It is preventable. It is worth repeating every single month that we would never tolerate creating that risk in any other setting. And I say this because we cannot allow ourselves to become numb to the reality of what this means for real people in the jails and the real people who love them. And look, I think we all sense a lot of fatigue, at least I do, in this meeting and beyond this meeting about COVID-19. It has been a hard year, and of course harder for some than others, but we just can't stop pushing because the stakes are so high. We cannot lock people into an inherently risky setting against their will and say, we're doing what we can. It's just not enough. And what we heard today is just not enough. I think we all know some of the basic facts. You know, the number of people in these housing units too high. And I'll say it again, 1,600 people, that is over a third of the jail population, are in dorms above 50% capacity. And what that means is over a third of the jail population cannot follow CDC guidelines about distancing. They can't. And I hear, and frankly, I appreciate Commissioner Brand's candor about the lack of staffing resources and her inability to commit to units below 50%. What that means is that the city has a huge problem that it needs to solve. The lack of decarceration is not okay. And all of these dangers will only increase as the resurgence continues and the population keeps going up. We cannot allow the actors in the city to say that the problem is everybody else. CHS must renew public calls making clear to an unconvinced judiciary, an unconvinced prosecutor bar, that the jails are dangerous. DOC has to join that public call. It has to make clear what it cannot do and what that means for the health of safety of everyone in the buildings, including city employees. And the board, thank you for your letter. You must continue to sound this alarm in public to anyone who will. And of course, about testing, there are many issues, but I can't let this moment go without saying that there is absolutely no excuse for not having mandatory routine testing of staff, who CDC studies and other jail and prison systems make clear are a tremendous vector for transmissions. And here's what we did not hear today. We tried to mandate testing for staff, but we ran into labor problems and we're working on it. Nearly a year into this pandemic, and they haven't even tried. And all of these things together, the insistence on relying on the strategy in the spring, the refusal to have routine testing of staff and people in custody, the failure to require exposed staff to quarantine or provide a negative test result before coming to work simply because they're asymptomatic, which means we know now that they could still be infected, is a refusal to adapt to our ever-changing understanding of a novel virus, and that refusal has a human cost. One last word about vaccinations. And I want to sincerely say that I appreciate Dr. Yang and her colleagues advocating that people in custody be vaccinated. I believe that she's doing that, and thank you for doing that. But I just need to be clear. Jail staff should absolutely be vaccinated. We are glad that they're being vaccinated. But every single day that we vaccinate jail staff without giving that access to people in custody is a day that this state is telling people in custody that their human value is less. It is transparently cruel. It is wrong. And when they are being incarcerated by a system that refuses to take the necessary steps to reduce the population and better detect infections within the population, the absolute least we can do for them is offer them a vaccine that can save their lives. It is critical. And finally, I just want to say, I know we all want this to be over. We all want a normal world where we don't have to fear shaking the hand of someone we met or telling our loved ones we can't see them because the risk is too high. We want to stop talking about COVID at these meetings. I know we all do. But the truth is, public health officials tell us we cannot yet relax our restrictions, even with a vaccine in sight. People who are vaccinated may still transmit the virus. We just don't know because this is so new. And the distribution of that vaccine is slow. We cannot stop protecting one another. We cannot stop seeking to protect people in the jails and the people who are in staff there. There's still too much at stake. Thank you very much for hearing me.
Thank you, Kayla. Our next speaker is Martha Greco. I don't see her on the line.
Just one moment. Starting my video, starting everything up.
Okay, there you go. Great.
Can everyone see and hear me okay?
We can, yes.
Thank you. My name is Martha Greco. I'm an attorney at the Bronx Defenders. I want to begin by reminding the board that people in custody are facing an unprecedented delay in trials. We are public defenders with active cases pending in the courts, and we have come before this board many times throughout this pandemic to ring this bell. Clients are languishing with no justice on the horizon. Our clients' experience of incarceration is compounded by that reality, the knowledge that there's very little they can do to move themselves forward. The fear that we on the outside have of contracting COVID, our clients experience that same fear, but have no control over their medical care. They have no control over where they will sleep at night and who they will interact with. And they have absolutely no sense of when they will be released because courts are effectively closed. I have multiple clients going on their third year at Rikers with no other holds besides an exorbitant amount of bail their families can't pay. It's a situation that might disturb the United Nations, and it's happening on your watch. The few opportunities our clients have to exercise their rights have proven impossible throughout the pandemic. There are no lawyers coming on and off the island. There's no true law library access, nowhere to drop off grievances and Article 78s as reported by our clients. The board has not reviewed the grievance process in over 2 years, and its last review identified a completely broken system that nobody has fixed. When we submit complaints on crucial issues like lack of PPE, safety threats, urgent medical needs, sometimes DOC responds, and sometimes they just ignore us. When OCGS does investigate and bother to respond, they always tell us your client withdrew the complaint. Every single day that the board fails to implement oversight of restrictive housing, people are sentenced to torturous terms in solitary confinement with no due process. Just last week, we dug deeper into one of our clients' claims that he was in solitary for a non-qualifying, non-violent infraction, and he was absolutely right. This client's experience of isolation began with a mental health crisis and is a classic example of the way DOC abuses the use of punitive segregation. It took weeks of relentless advocacy to get DOC to address the due process violations raised, and this client is still in restrictive housing ESH level 1, a placement based on an infraction of which he's been cleared. The captain and warden claim confusion about why he's there, and he has received no mental health support beyond a confirmation that he wasn't trying to take his own life in solitary. DOC's claims of disciplinary due process that is uncomplicated and working well is simply not true. We shouldn't have to scramble to spring people out of lockdown, frantically emailing DOC lawyers. We should be there from the beginning, making sure that whenever DOC attempts to infringe on our clients' basic human rights, there is a full and impartial hearing that actually determines facts. Why isn't this implemented immediately? The board has stated its commitment to true transparency in the disciplinary process, yet our clients continue to be harmed and the process has never been more opaque. Why can't we start the process of transparency now? Every day the board does nothing, the most marginalized people in the city suffer.
Thank you, Martha. Thank you. Our next speaker is Ashaki. Okay, I see your hand. You may begin.
Can you see me? Can you hear me?
We can hear you.
Can you see me?
No, we can't see you, but we can hear you.
Okay, can you, hold on a minute. Can you see me? Hear me?
We can hear you, still can't see you.
Okay, well, my name is Asaki Antoine, representative of the Correctional Officers Benevolent Association. CDC guidelines as it pertains to social distancing in the jail setting is still not being adhered to. Precautions to minimize the risk of spreading COVID second wave outbreak has failed. In the facilities, the cells and dormitories remain full to capacity. There is no social distancing in the day room where inmates congregate. Correctional officers' health and safety are also affected by this failed policy. In a memorandum written by the State Commission of Correction Chairman, Mr. Alan Riley, referenced that detention facilities are at a greater risk of the spread of communicable disease due to the number of individuals living in close proximity to one another. I tour the facilities and housing area routinely, and I address the concerns from officers, inmates, and civilians as it relates to COVID and social distancing. I encourage you all once again to tour the facilities with me so that you can get a clearer physical picture as to what is really going on in the facilities. December 11, 2020, President Benny Basio of the Corrections Officers Benevolent Association, along with 6 correction officers, spoke before the City Council regarding the proposed end of punitive segregation. Testimony was presented regarding assaults on officers, officers splashed with feces, female officers sexually groped by inmates. After the meeting, assaults continued to rise against correction officers. Officer A was punched in the mouth by an inmate, which resulted in 2 of his teeth knocked out. Officer B was conducting a tour of inspection when she was doused with feces. Officer C afforded an inmate an option to come out of his assigned cell. Upon opening the cell door, without warning, the inmate attacked the officer, punching him in the face and leaving the officer unconscious. Inmate-on-inmate assault has increased. Slashings are a weekly occurrence. All of these incidents were unprovoked. Little to no consequences for these heinous crimes in the jails. No accountability for the inmates who blatantly disregard the rules set forth. No protection for the victims, which are officers, civilians, and inmates, who most times remain disfigured and scarred for life. Inmates continue to embolden their assaults against correctional officers because many of you refuse to hold them accountable, which in the end has created an unsafe environment for everyone who live and work in a jail setting. Imagine inmates who commit crimes against officers and other inmates are still in the same housing area without discipline to repeat the same behavior. Why is this acceptable, and why are they not being held accountable? No one besides the Correction Officers Benevolent Association has publicly spoken out against the brutal assaults of correctional officers. Why is that? Thank you.
Thank you. Next speaker is Simone Spring. Or Sprang. Simone.
Hi, can you hear me?
Yes.
Okay. Good afternoon. My name is Simone Spear, and I'm the Jail Services Social Worker at Brooklyn Defender Services. I've spoken to this board many times in the past about the serious lack of communication on behalf of CHS when it comes to notifying people of their COVID-19 test results. And I'm here again today to once again bring this issue to your attention. We are now 11 months into the COVID-19 pandemic. Cases are rising in the city, there's an active infection rate within the jails, and we have a jail population of over 5,000 people that continues to rise every single day. We are still in a public health crisis, and the most basic of things that CHS can do for people in custody is communicate. Communication is crucial at any time, but especially now. BDS, as I'm sure with other defender offices, has received an increase in calls from people in custody, many of whom are deeply concerned about their safety. The heightened fear we are witnessing is exactly what we saw in the spring at the beginning of this pandemic. People didn't know what to do, what their test results reported, or even how to access a test if they are concerned about exposure. 11 months later, and it feels very much like we're back to where we started. Over the course of this pandemic, the majority of people BDS has spoken to in custody have never received their test results. We informed the board months ago how it's now become the responsibility of our office to request medical records so that we can inform people of their results. After people take a test, they are moved to other units or other facilities without having the peace of mind on the status of their test. They are overwhelmed with fear and anxiety because without knowing their results, they don't know if they are spreading the virus. At the same time, people in housing units are fearful of new people entering, especially when those new people don't know their test results either. Mayor de Blasio gives almost daily press briefings encouraging people to get a test so that we can stop the spread. If you or I get a test, we're informed via email, letter, or other means as soon as those results come in. Yet for people in custody, we hold a lower standard, that it's not a priority for people in custody to know the status of their own test results. We're sending the message that it's just not a big deal. It's shameful that after 11 months of us requesting CHS to notify people, very little has changed. Just recently, we spoke to someone who, by word of mouth, was informed that his housing unit had a positive case. He didn't hear it from CHS nor DOC, and it wasn't until he noticed a flyer posted on the wall of his unit that he realized his unit was on quarantine status. We bring you these experiences every month, and it's troubling that the agencies responsible to care for people in custody can't communicate test results and can't communicate their plans on procedure or safety measures as the spread continues. Thank you.
Thank you. Our next speaker is Minister Dr. Victoria Phillips. Ms. V.
Can you hear me?
Yes.
Okay. Peace and blessings, everyone. It's Dr. V again. I just want to touch on some things, and then I want you to actually hear from someone on the inside. It's a shame in 2021 we still don't have a way for you to directly hear of our community members that are still waiting for their fair day in court. So just really quickly, I just want to go over today. It was mentioned that over 33,000 video visits have been done. But yet this board has heard from loved ones where DOC has actually called them actually when the visit was supposed to be going. Like if the visit was supposed to start at 11 a.m., they didn't get a call at like 11:04. Hey, you're supposed to be on a visit. That's unacceptable. But I didn't hear the board ask about any of that. Please follow up. December 11th, the city council did have a hearing, and Commissioner Brand testified. She was asked many questions, and one of the questions she was asked was, what's the most dangerous population? And she said young adults. Well, I've testified many times before this board of being part of the young adult advisory board for DOC for like 6 years. I even sat on it with Chief Perello at one time, and then he left. But my point is that in such a serious time in our lives, such a global pandemic, why hasn't the advisory board met at all? The last time we met was February 4th, 2020. What's going on? We all have access to internet, and before then, they actually had stopped the ability to call in if you couldn't make it to the Boulevard building. I feel like those was direct ways to stop the advisory board, and I've testified to you all before how Ms. Torres said that they would stop it, but she know that I would run straight to City Hall, and I have run straight to City Hall, and I'm reminding this board in 2021 that the advisory board is needed because everything that Commissioner Brand has ever spoke to you about that was positive and that they are doing came from ideas in the implementation of all of us who worked on that advisory board. Also, I'm so sorry. It's just so much. I'm just going to go. I don't want to waste any more time. Please listen to this.
Really about law library. Once again, they're very inadequate. They're not bringing back anything. They come every day to take our request forms, but they have not been bringing back anything, which is further hindering our, development of a defense for any kind. And that's really my main concern.
Okay, so have you recently submitted something that you didn't get back properly?
I've been submitting things since August of last year, and I'm still waiting for multiple requests that I put in. They brought back like motions and things, but case laws, the real important things that I request for, I've never gotten anything of those sorts.
So that's really important because this is something that I keep bringing up to the Board of Corrections. They actually have another meeting coming up. You have 1 minute left. This Tuesday. Could you tell me what day it is so I can prove to them that this is still a problem?
Yes. Today's January, Sunday 10th. January, the Sunday, the 10th of 2021.
Okay. And your issue is still law library and things not coming back.
Correct.
Okay. So that's just a piece of direct people that Sunday, like I said earlier in my testimony, I couldn't even help my father. I couldn't even help my father who was just having heart surgery because so many people from the island and off the island was calling me because they know this meeting was going on. Please, in 2021, you need to find a way to have direct access from people that are incarcerated to directly speak to you. It's so important. And I also think this board needs to request that Warden Caputo actually attend the next meeting because his voice is very important, especially when we talk about the young adults. I was very active in going to the jail before everything closed down as a advisory board member. And also, I heard that I need to tell y'all from a DOC staff actually told me to tell y'all check out 9 South. Some certain things going on in there, so check out 9 South and RNDC. And once again, I want to reiterate the new cell doors are working, but the ones that are not new are not working. That's very important when we talk about safety.
Thank you, Ms. V. Thank you. Our next speaker is Tasha Cruz. I don't see Tasha on here. Let's go to Brad. Brad, are you on? Yes, I see you. Okay, I see your hand, Brad.
I'm just trying to get my video set up. Apologies. Hi, can you see me?
We can hear you. We can't see you.
Oh, sorry. How about now?
Still? Yes. Now we can.
Okay. Thanks very much. So this past July, Governor Cuomo's bail reform rollback showed us that the size of our jail population is essentially a political decision. In the middle of a raging, deadly pandemic, it's also an urgent public health issue, obviously. We know that our jail population is disproportionately poor, medically vulnerable people of color. We know that city jails are particularly fertile breeding grounds for COVID-19, and we know that allowing the virus to spread in our jails leads directly to more illness and death in the communities, especially those poor communities of color that have been hit the hardest. It's against this backdrop that I was deeply disturbed to hear Correctional Health Services Senior Vice President say that they didn't feel the need to sound the alarm this time around about our jails because that alarm has already been sounded. In the spring, we saw what happened when CHS leadership gave public voice to the urgent need for decarceration. We saw Dr. McDonald and Dr. Bedard out in the public sphere advocating firmly and forcefully for decarceration. And we saw that the effect of that was, more than 300 of the 550 or so city sentenced people were released. We saw hundreds of people in on technical parole violations with no pending charges criminally. We saw that they were released and the jail population plummeted in a way that no doubt saved countless lives and saved countless people from serious illness, both in the jails and in the community. And we saw that CHS sent, many hundreds of letters and many hundreds of people were released as a consequence of those letters. Now we're seeing a jail population that is way up. DOC is refusing to release anyone that's in on city sentences, saying that they're all too dangerous, despite the fact that they're going to be released in a matter of months anyway, since the maximum you can serve on a city sentence is 8 months. We're seeing that CHS has sent something in the neighborhood of 1,500 new letters, and 9 people have been released as a consequence of this. These are decisions that human beings can make to release more people, the mayor's office, the governor, parole officials, DOC, and yet they're not making those decisions. So the idea that the alarm does not need to be sounded in the face of these stark facts is just deeply disturbing to me. I know obviously CHS did not increase the jail population. That is not their doing. But when they decline to advocate for decarceration in the forceful way that they did the first time around, they are letting the actual decision makers, the people that I just listed and more, off the hook for refusing to do what needs to be done to bring this under control in the jails. But CHS just released a new report that only goes through December 27th, unfortunately, under Local Law 59. And since then, we have seen 45 new infections among the jail population through the most recent snapshot data that they're releasing. The idea that this is not urgent, the idea that we don't need to decarcerate or sound the alarm about that. And then the last thing I want to say about the things that we were told today, CHS said that they have their current average positivity rate among the jail population is around 5%. It's virtually certain to be a huge underestimate because from CDC studies, we know that mass testing, which they've refused to engage in, brings about an average of like a 12-fold increase in prevalence rates. And we also know that they're not testing everybody that's even been known to be exposed among the jail population. Even if we assume that mass testing would only triple the prevalence rate in the jail or the positivity rate in the jail, we're looking in the neighborhood now of 15%. Can you imagine what effect that might have on the ability to advocate for the necessary decarceration if we were to have an honest look at what's going on in the jails through meaningful testing that actually samples the population in a way that tells us what's going on? But as it stands, we've just decided for whatever reason, whether it's because we've asked too much of these people as human beings, which we no doubt have, or because we don't have the resources to do the things that we should be doing, we just aren't pushing hard enough to get people out of our jails. It needs to happen urgently. This is going to go on for a long time now.
Thank you.
Thank you.
Thank you. Our next speaker is Tanya. Let's see Tanya on here.
I think Tanya had to step away.
Okay, so let's go to Kelly Grace Price. Kelly, I don't see her hand. Okay. Let's go to our next speaker, Julia. Okay, Julia, I see your hand. You may begin.
Okay, great. Can you, oh, I'll start my video as well. Sorry, just a minute. Okay, can everybody see me?
Yes.
Great, thank you so much. Good afternoon. My name is Julia Curbs, and I'm a corrections specialist at New York County Defender Services. I come before you all today to raise questions about upcoming efforts to vaccinate incarcerated people in DOC custody. While NYCDS strongly supports vaccine administration for willing, informed clients, we wish to raise questions about informed consent and medical continuity for those people who will ultimately receive the vaccine while in custody. As the COVID-19 pandemic continues to ravage New York City jails, access to vaccinations for people in custody is essential to protecting their health, as well as stopping the spread in our jails and communities. However, electing to receive the vaccine is a serious personal and medical decision that should not be taken lightly. Many of our clients have limited access to healthcare systems and advice from medical professionals, both prior to and during incarceration. And it is essential for them to be able to ask necessary questions about risk factors, potential complications, and any logistical or health-related concerns about receiving the vaccine. As vaccine rollout begins in the jails, we would like to reinforce that incarcerated people should be given notice prior to receiving the vaccine so that they have time to seek answers to any questions they may have about vaccination. Similarly, continuation of care is a major concern surrounding vaccination programs within the jails. Our clients frequently experience lapses in treatment programs and prescription medication schedules when entering or exiting custody independent of the COVID-19 pandemic. And these kinds of medical inconsistencies are particularly troubling in the context of the 2 COVID-19 vaccinations approved in the US as of today, both of which require 2 doses. In 2019, 29% of people incarcerated on Rikers Island remained there for less than 4 days. And we know that many more are incarcerated for less than 3 or 4 weeks, the timeframes for receiving the second doses of Pfizer and Moderna's COVID-19 vaccines, respectively. Last week, NYCDS sent a letter to DOC, CHS, BOC, and MOCJ for details about the city's plan to vaccinate incarcerated people. A copy of our letter is on the BOC website. But of particular concern is this question: what is Correctional Health Services' plan for ensuring all eligible people receive both doses of the vaccine? Will vaccinations be administered exclusively to sentenced people or to people whose cases indicate longer periods of incarceration that would allow them to receive both doses? Any person who enters DOC custody is at far higher risk than the general public of contracting COVID-19, and with proper preparation and community coordination, any follow-up care and second doses should be able to be obtained post-release for those people who leave custody between doses. Vaccine discrimination should not occur based on length of stay in custody, and we need to know Correctional Health Services' plan to safely and efficiently vaccinate people in custody and after their release. Though we recognize that availability of vaccines is largely dependent on state and city-based allocation, it is essential that DOC and CHS establish a reliable and lasting framework to protect those in the system. We are pleased to see the arrival of the first vaccines in our city and its jails, and we implore everyone to keep in mind that incarcerated people need protection. Their lives and the city's public health infrastructure depend on it. Thank you.
Thank you. I understand that Kelly is back on. Yes, I see your hand, Kelly. Bennett, do we have Kelly Grace Price up?
Yeah, I'm trying to.
Okay, there, I see she just popped up.
All right.
You're muted. Okay, there you go.
Stanley, it's Grace. Thank you for coming back to me. I find this web tool very irritating. I find that many of the advocates who come to the option to raise our hand or use our video, and we've been saying this ever since this application has been employed, and we'd really like someone to get to the bottom of it. Bennett, I know you're working hard, but come on, this is beyond the pale. Something else that is completely beyond the pale is Commissioner Braun's question I heard come from BOC. She was asked what happens when test and trace triggers alerts that DOC staff has been exposed to COVID. Are those people removed from duties, DOC duties? What happens at that point? And the response came back from DOC Commissioner Braun, oh, we can't do anything because we can't mandate testing. Again, Commissioner Braun is employing a diversion and gaslighting instead of answering the question. And it's entirely frustrating to sit and listen to her engage with you using these tactics and watch the board for them again and again. Please stop letting her gaslight you like a pimp. It's so frustrating. I turned it to me. It's the same testimony last December. Remember, the co-mingling variant request was brought in 2015, and it wasn't until 2019, December of 2019, that I realized that the data being turned over that accompanied the co-mingling was false. That in fact the DOC had only been reporting to you for the last 5 years co-mingling data of youth that were placed in adult units. They were not including co-mingling data of adults that were placed in youth units, and they had been doing this for 5 years and no one noticed it. Please pay attention to my testimony. I went to great pains to point out their inaccuracies in data. I really hope someone's keeping an eye on this discrepancy right now. I noticed that the DOC has since pulled the reports from their website that show that they had manipulated data. I downloaded all those reports last year in December before I submitted my testimony, and I'm happy to email them to anyone at the BOC on this issue. Please ask your analyst who's following up on the co-mingling issue to follow up with me, because I know the person that worked on this issue before quit in disgust from the BOC in 2019. My name is Kelly Grace Price. Thank you so much. Please pay attention to my written testimony.
Thank you, Kelly. And our last speaker is Victor. We have Victor. I don't see Victor on here. I don't see Victor on here. So that concludes our public comment. Just a reminder that the board's next public meeting is scheduled for February 9th, 2021 at 9 a.m. This meeting will likely be held via WebEx. Sorry for all of the technical glitches of this application, but this is the application we need to use to hold public meetings. We will continue to try to seek technical support to address some of those glitches, but this is the application we have. Details will be available on our website, and we will send an email to all interested parties. That concludes this meeting. I want to thank all the board members for participating and being engaged. I want to thank all of the comments. As you know, the comments are part of our public record. We take the comments very seriously as we think about our work and think about how we engage with the Department of Corrections and Correctional Health. That concludes our meeting for today. Thank you, everybody.
Mr. Chair,
Thank you.
my hand up before and no one, Camacho Robert, as you see, I had it up for a while. Then since you started in regards to anyone, and I guess you overlooked me. Not too sure.
I didn't have your name.
Yeah, Camacho Robert, ROBERT CAMA.
Yes, I had you on the first one. You want to say something, Robert?
Yeah, yes, I wanted to be fair, and also thank you. If this is what I heard you say, that you have a new board member from Bushwick, is that correct?
We have Marco. Marco, you on?
Thank you, Marco, for being part of this community and also helping us in any way, because as you know, we do have people from Bushwick incarcerated. We do have people from Bushwick that works in Rikers Island. We do need to work together to make sure that the services that they're providing and the safety that they have comes back to this community, it comes back to the people that are there. And we need to make sure that we have a public safety committee. I'm the chair of the community board, and each board have a public safety committee. Maybe you can come and speak in regards. I also want to thank Victoria, because why does she have to submit proof that things are happening and not listening to her, that she's been there a while? We really need to focus and work and make sure that the people that are being served and the people that did what they do, make sure that we help them in any which way, because, and also come back to this community. We have a public safety committee, and we also want them to make a presentation, because a lot of people need to know what's going on and not wait until something happens to go out there and start protesting and demand. We need to step up right now, because it's going to be a mayor. People are running for mayor, you know. We need to step up to the plate, and I also want to thank this board for giving me the opportunity to speak. So we really need to step up, and we really need you, new board member, if you want to come. The CB4, or you got to go on the way, get the number. We can get together and we can have you make a presentation to the community at large. So we really all need to all community boards have public safety committee. Let's not wait until something happens to start protesting and fighting. Let's get together and make sure that we do what we have to do. Let's get tested. Let's make sure everybody get their shot. Whoever don't want it, guess what? It is what it is. But whoever want it, let's give it to them. Let's not leave stuff in the refrigerator die. Let's make sure that we give it to them and make sure that we have all the proper equipment that they need to be. And also, so thank you, board members. Thank you. God bless you. Be safe. Wash your hands and put your mask on.
Thank you, Robert. That is the last word of this meeting.
Sorry, Stan. Sorry to interrupt you, Stan. Irene Zidano just messaged that she had meant to speak as well.
Okay, do we have her up? I see her.
Hi, everyone. Can you hear me?
Yes, we can hear you, Irene.
Okay, I'm so sorry. Thank you for squeezing me in at the end here. My name is Irene Sedano, Jail Services Advocate with Brooklyn Defender Services. For several months now, people in custody in our office have been informing DOC and the board via email and in past BOC meetings about the lack of PPE, lack of laundry services, and lack of clothing available to people in custody. First, I want to talk about the lack of PPE. I want to push back on the notion that people in custody do not want to wear their masks. On numerous occasions, our office has witnessed firsthand people in the council booth without a mask. And when we ask why they don't have one, we're told repeatedly across numerous facilities that DOC said they ran out. They don't have any. Just yesterday, our office met with a man that has been using the same reusable mask for 3 weeks. We're now 11 months into this pandemic, knowing full well how masks are crucial in stemming the spread and protecting people. DOC leadership repeatedly purports how they have, and I quote, an ample supply of PPE, how it's logged, and how there's a system in place to account for units that are running low. So if true, why does our office have to repeatedly tell DOC when masks are not being offered? This is a basic request, and there should be no reason and no hesitation on the department to ensure there's a sufficient supply of PPE available to all people in custody and their staff. It protects everyone in the jails, people in custody and staff working with them. Next, I want to discuss the lack of laundry services and clothing. BDS has been reporting this issue for months now. We brought it to the board's attention in November. People are reporting going weeks without laundry services, and it's resorting to them utilizing the sinks to hand wash the clothes they do have. For others, they're receiving one pair of pants or shirts and feel they have no other option but to either wear the same clothes for weeks on end or wear nothing but their underwear during winter while their clothes hang to dry over their beds. Just recently, we received a report how one man has never been provided underwear by the department, so he now wears 2 pairs of pants. In another case, we met with a man who was in solitary confinement, and because he didn't have access to laundry services, his clothes became so grotesque that he felt he had no other option but to throw them out. When people advocate for themselves in the jails, DOC repeatedly says they have run out or they'll have to wait for the next shipment of clothing. We've been hearing these complaints for months now with no adequate response from DOC nor BOC about why people are not receiving clothing or adequate options to clean their clothes. We call on both agencies to provide answers and next steps that would ensure people are provided with basic hygiene and clothing. Thank you.
Thank you, Irene. Does Bennett, that concludes this meeting?
Yep, that's right.
Yep. Thank you, everybody, for participating. And as I said, the next meeting will be February 9th, 2021 at 9 a.m. and it will be through WebEx. Thank you again. Have a safe day and be safe. Take care.
Thank you. Thanks, Stanley.
Okay, take care, everybody.